53 Peptic ulcer disease. Francis K. L. Chan, James Y. W. Lau. An ulcer in the GI tract can be defined as a 5 mm or larger break in the lining of the mucosa, with appreciable depth at endoscopy or with histologic evidence of submucosal extension. An erosion is a break less than 5 mm. The distinction between an ulcer and an erosion is somewhat arbitrary. The term PUD is used to include ulcerations and erosions in the stomach and duodenum from a number of causes. These lesions are called peptic because the enzyme pepsin, proteolytic at an acidic pH, see Chapter 51, plays a major role in causing the mucosal breaks, regardless of the inciting agent. Decades of research focused on the role of gastric acid secretion and the effects of stress, personality type, and genetics in the pathogenesis of PUD. The discovery of the histamine 2, H2, receptor and development of H2RAS1 and subsequently PPIs, led to major changes in the management of PUD. The discovery of HP and its role in PUD, see Chapter 52, transformed PUD from a chronic, recurrent disease to a curable 1.2 HP. Infection remains an important cause of PUD in the world. In developed countries, frequent use of NSAIDs, including low-dose aspirin for cardiovascular indications, has emerged as a leading cause of PUD, especially among the aging population. 806 Epidemiology. The epidemiology of PUD has undergone remarkable changes in the past 2 centuries. The risk of developing PUD, and dying from PUD, increased in successive cohorts born between 1840 and 1890, and then declined thereafter. 3 There was a peak in the incidence of GU in the first half of the 19th century and a subsequent peak in the incidence of DU in the second half of the 19th century. Sonnenberg proposed a birth cohort effect to explain the peaks in the incidence of, and mortality from, peptic ulcers. HP infection acquired during childhood or adolescence became manifested as peptic diseases in later years. As HP infection gradually declined in the population over time, the prevalence of infection also gradually shifted from a younger toward older age groups. The incidence of DU and GU has declined in parallel with the decline in the prevalence of HP infection, likely a result of improved sanitary conditions and a safer food and water supply. Based on physicians' diagnoses, the annual incidence of PUD ranges from 0.14% to 0.19% in developed countries. Based on hospital diagnoses, the incidence is lower, 0.03% to 0.17%. The prevalence of PUD ranges from 0.12% to 4.7% for physician-diagnosed, and from 0.1% to 2.6% for hospital-diagnosed case series. 4 There is a wide geographic variation in the prevalence of PUD. In an endoscopic series involving 1,022 volunteers from Shanghai, China, average age, 48 years, the prevalence of PUD was 17.2%, of whom 93% were infected with HP. 5 The most frequent complication from PUD is bleeding. The reported annual incidence of bleeding among populations varies from 19 to 57 per 100,000 individuals, 0.02% to 0.06%. Peptic ulcer perforation, pulp, less frequent than bleeding, has reported incidences of 4 to 14 per 100,000 individuals, 0.004% to 0.014%. 6 Along with a decline in uncomplicated PUD cases, there is a similar decline in incidence of ulcer complications in recent years. Lane and colleagues 7 used a national inpatient database to calculate the annual incidence of, and mortality from, GI complications during 2001 to 2009. During this time period, the incidence of peptic ulcer bleeding fell from 48.7 to 32.1 per 100,000. Over the same period, the age and sex-adjusted case fatality rates from UGI bleeding decreased from 3.8% to 2.7%. In 2009, the case fatality rate for UGI bleeding, 2.45%, was considerably lower than for UGI perforation, 10.7%. In a nationwide population-based cohort study of 403,567 Taiwanese patients, hospitalizations for complicated peptic ulcers decreased significantly over a 10-year period. Thus the annual incidence of hospitalizations for bleeding dew or for perforated dew fell from 108 to 40 and from 9.8 to 5.8 per 100,000, respectively. A similar decline was evident for bleeding and perforated gus, from 117 to 61 and from 11 to 6 per 100,000, respectively. Etiology and pathogenesis. The principal risk factors of PUD are HP infection and NSAID use, Fig 53.1, and as will be discussed, many patients with PUD have both of these risk factors. On the other hand, PUD patients may have neither of these risk factors, HP negative, NSAID negative ulcers. Some of these latter patients will have another cause of ulcer such as gastrinoma, ZES, see Chapter 34, whereas others will have ulcers that are idiopathic. Duodenal gastric. Fig 53.1 pie charts depicting conditions associated with PUD. The percentages shown are rough approximations based on studies from Western countries. The relative contributions of HP infection and NSAID use to peptic ulcer vary considerably among different populations and, within populations, vary with age and socioeconomic status. Also, the separation depicted in this figure is somewhat artificial because NSAID use and HP infection often coexist. HP infection. The prevalence of HP infection varies widely among countries in the world, see Chapter 52. In series reported between 2009 and 2011, the prevalence of infection ranged from 7% to 87%, depending on the methods of diagnosis and the population that was sampled. The lowest prevalence was observed in the USA and European countries, 7% to 33%, 0.9. Those reported from Japan and China ranged from 56% to 72%. In general, the rate of HP infection is declining. Feinstein and colleagues studied hospital discharge records for PUD in the USA between 1998 and 2005.10 in parallel with a decline in annual hospitalization rates for PUD, from 71.1 to 56.5 per 100,000, there was a decrease in hospitalization due to HP-related disease, from 35.9 to 19.2 per 100,000. The prevalence of HP infection in patients with bleeding ulcers remains high. Sanchez Delgado and colleagues compiled 71 studies containing 8,496 patients with bleeding peptic ulcers and found an HP infection rate of 72%. The use of an HP diagnostic test after the index bleed was associated with high HP prevalence. 11 As discussed in Chapters 51 and 52, HP causes an antrum-predominant gastritis in 10% to 20% of infected patients, which results in high gastric acid secretion and an increased risk of DU. The increased acid output from the stomach results in increased acid load to the duodenum that can result in gastric metaplasia in the duodenal bulb. 12 Some believe that the metaplastic epithelium then becomes infected with HP from the stomach, resulting in focal duodenitis, technically, gastritis, sometimes followed by erosion and ulcer formation. Most patients with HP infection have a pangastritis involving both the antral and fundic mucosa that lowers gastric acid secretion 13 and predisposes to GU formation. In these individuals, it is proposed that weakened mucosal defense mechanisms, see Chapter 51, rather than high acid secretion, are what predisposes to gastric ulceration. The role of HP's genes and their protein products in the pathogenesis of PUD is discussed in Chapter 52. Use of aspirin and other NSAIDs. Aspirin is increasingly used on a regular basis for the prevention of cardiovascular events, either alone or in combination with a platelet adenosine diphosphate inhibitor such as clopidogrel, dual antiplatelet therapy. NSAIDs are used on a regular basis by approximately 11% of the U.S. population. Regular use of NSAIDs increases the odds of GI bleeding up to 5 to 6-fold. 14 Serious ulcer-related complications often leading to hospitalization occur in 1% to 4% of NSAID users. 15 NSAID users who also take aspirin are at an especially high risk for complications. In a population-based study from Denmark, the odds ratio for GI bleeding in people taking low-dose aspirin alone was 2.6, and this ratio increased to 5.6 in patients who were also taking an NSAID. 16 In a national study of mortality associated with a hospital admission for adverse GI events related to NSAID use in Spain, the death rate attributed to NSAID/aspirin use was 15.3 per 100,000 population compared to 2.5 per 100,000 of the general population. 17 The gastric and duodenal mucosa have several defense mechanisms protecting them from digestion by acid and pepsin, see Chapter 51. NSAIDs cause mucosal damage through disruption of mucous phospholipids, cell membranes, and by uncoupling mitochondrial oxidative phosphorylation, but most evidence suggests that NSAIDs damage the gastric and duodenal mucosa by suppression of prostaglandin synthesis. 18 COX isoforms COX-1 and COX-2 are responsible for the synthesis of prostaglandins. COX-1 is expressed in the stomach and helps maintain the integrity of gastric epithelium and the mucous barrier. COX-2 is not expressed in the healthy stomach but is rapidly expressed in response to the cytokines generated by inflammatory processes. Conventional NSAIDs such as ibuprofen inhibit the COX-1 and the COX-2 isoenzymes more or less equally. COX-1 inhibition reduces prostaglandin synthesis, which leads to a reduction in mucosal defense. Animal experiments have found that neutrophil adherence to the gastric microcirculation plays a critical role in initiating NSAID injury. Neutrophil adherence liberates oxygen-free radicals, releases proteases, and obstructs capillary blood flow. Inhibition of neutrophil adherence has been shown to reduce NSAID-induced damage. In addition, two gaseous mediators, nitric oxide, NO, and hydrogen sulfide, H2S, contribute to maintaining the gastric mucosal barrier. NO and H2S increase mucosal blood flow, stimulate mucus secretion, and inhibit neutrophil adherence. 19 NO releasing and H2S releasing derivatives of NSAIDs have been shown to protect against gastric damage when compared to the parent drugs. Gastric acid plays a secondary but important role by turning superficial mucosal lesions into deeper injury, interfering with platelet aggregation, and impairing ulcer healing. 20 HP infection appears to influence the risk of PUD in patients receiving NSAIDs. A meta-analysis showed that HP infection raised the risk of peptic ulcer bleeding more than six-fold in patients receiving long-term NSAIDs, whereas HP alone and NSAID use alone raised the risk by 1.79-fold and 4.85-fold, respectively. 21 An updated meta-analysis showed similar findings. 22 Among patients who are about to start NSAID therapy, eradication of HP reduces the subsequent risk of ulcer development. 23,24 A systematic review has shown that testing for, and eradication of, HP lowers the risk of peptic ulcers among NSAID users. 25 However, eradication of HP infection alone is insufficient to prevent peptic ulcer bleeding in NSAID users at high ulcer risk. 26,27 There is also evidence that HP infection increases the risk of PUD in patients receiving low-dose aspirin. Among HP-infected patients with recent ulcer bleeding who continued to take low-dose aspirin, successful eradication of HP infection resulted in a very low risk of recurrent ulcer bleeding, similar to that seen with aspirin/omeprazole CO therapy. 26 This low risk of ulcer rebleeding after eradication of HP was not seen in patients with bleeding ulcers who continued to take NSAIDs. In a long-term prospective cohort study, 28 HP-infected low-dose aspirin users, less than or equal to 160 mg/day, with bleeding ulcers who resumed their aspirin had a low risk of recurrent ulcer bleeding after eradication of HP, a risk that was not significantly different from the risk in new aspirin users with no history of ulcer disease, 1 bleed per 100 patient years. In contrast, aspirin users with bleeding ulcers but without Fig 53.2a, endoscopic view of a clean-based antral goo in a patient taking an NSAID. Tests for infection with HP were negative. B. Endoscopic view of a DO in a patient with a positive rapid urease test for HP. There was no history of NSAID use. HP infection, past or present, were at high risk of recurrent ulcer bleeding with continued enteric-coated aspirin treatment, greater than 5 bleeds per 100 patient years. Other causes of ulcers and idiopathic ulcers. Deep ulcers and perforations of the stomach and duodenum have been described in cocaine and methamphetamine users, presumably due to mucosal ischemia. 29 Bisphosphonate therapy has also been associated with gastroduodenal ulceration. 30 Although esophageal injury with bisphosphonates is clinically more of a concern, there is little, if any, risk for PUD in patients taking glucocorticoids. 31 In combination with NSAIDs, however, glucocorticoids increase the risk of PUD above the risk with NSAIDs alone. 32 There is also a weak association between use of selective serotonin reuptake inhibitor antidepressants and PUD, especially in those with concurrent NSAID use. Smoking, stress, type A personality, and excessive alcohol use are some of the risk factors implicated for PUD. Although these factors can contribute to PUD, none has emerged as a sole cause of the disease. HP infection is a confounder that was not addressed in earlier studies. An uncommon cause of PUD is gastrinoma, ZES, see Chapter 34. 33 Systemic mastocytosis, see Chapter 37, is another uncommon condition in which multiple ulcers may occur in the stomach or duodenum. 34 Secretion of histamine by the mast cells is thought to result in the excessive stimulation of acid production through the histamine receptor. Associations between PUD and alpha-1 antitrypsin deficiency, chronic obstructive lung disease, and chronic kidney disease have been described. Several other diseases, e.g., gastric cancer, gastric lymphoma, Crohn's disease, can cause ulcers that can mimic peptic ulcers. Rarer causes of peptic ulcers include eosinophilic gastroenteritis, viral infections, e.g., cytomegalovirus, Behçet disease in immunocompromised patients, Helicobacter pneumoniae infection, and ulcers in a Meckel diverticulum with heterotopic gastric mucosa. With a global decline in the prevalence of HP infection, the proportion of patients with idiopathic ulcers has been increasing. Studies in North America have shown that more than 10% of peptic ulcers are not associated with HP infection or the use of NSAIDs. Whether the incidence of idiopathic ulcers is increasing or not is controversial. It has been argued that only the relative proportion, but not the true incidence, of idiopathic ulcers has increased as a result of a falling incidence of HP ulcers. However, there are prospective data showing that the absolute incidence of idiopathic bleeding ulcers has increased by fourfold. Importantly, patients with a history of idiopathic bleeding ulcers have a fourfold increased risk of recurrent ulcer bleeding and more than twofold increase in mortality compared to patients with history of HP ulcers. 35 Clinical features and diagnosis. The predominant symptom of patients with uncomplicated PUD is epigastric pain. Pain is typically associated with hunger, occurs at night, and is often relieved by food and antacids. Often patients complain of dyspeptic symptoms such as a bloated sensation and fullness. Some patients complain of heartburn that may or may not be accompanied by erosive esophagitis. Chronic NSAID users, typically older adult patients, can present with ulcer bleeding or perforation without prior ulcer symptoms. EGD is the procedure of choice for diagnosis of uncomplicated PUD, Fig 53.2a and b. EGD is more sensitive and specific than radiologic studies, such as UGI series with barium. Nevertheless, endoscopy is expensive and has the potential for complications, see Chapter 42. Therefore, the decision to perform endoscopy in a patient suspected of having PUD is based on a number of factors. As discussed later in this chapter and in Chapter 20, patients presenting with acute GI bleeding need endoscopic evaluation to allow an accurate diagnosis and for the administration of endoscopic therapy. Furthermore, patients with epigastric pain suggestive of PUD but also with alarm features such as weight loss or recurrent vomiting may prompt concern for gastric malignancy as well as require EGD, Box 53.1. If a DU or GU is found during EGD, gastric mucosal biopsies should be obtained for a rapid urease test to diagnose HP infection, see Chapter 52. Biopsies should also be taken from the edges of GUS because of risk of gastric cancer. Customarily, if the GU biopsies are benign, EGD is repeated 8 weeks later to confirm healing of the GU, because up to 4% of apparently benign GUS at initial endoscopy are subsequently found to be malignant. 36-37 Dyspeptic upper abdominal symptoms consisting of pain or discomfort in the upper abdomen are common in clinical practice, accounting for 2% to 5% of visits to family practitioners. See Chapter 14. 38 Owing to the high cost and impracticality of subjecting all dyspeptic individuals to prompt endoscopy, two other non-endoscopic strategies, besides UGI series, with its inherent lower sensitivity and specificity for PUD, have been proposed as an initial step in the Box 531 alarm features in patients with UGI symptoms * age older than 55 years with new onset dyspepsia, family history of UGI cancer, GI bleeding, acute or chronic, including unexplained iron deficiency, jaundice, left supraclavicular lymphadenopathy, Fierco node, palpable abdominal mass, persistent vomiting, progressive dysphagia, unintended weight loss *. These features should prompt EGD and often other testing to establish a definitive diagnosis. See Chapter 14. Management of suspected PUD, Fig 53.3. The strategies are: 1. Test and treat, based on a non-invasive diagnosis of HP infection and subsequent eradication therapy when HP is detected, and 2. Empirical anti-secretory therapy, usually with a PPI. Fig 53.3 AC and Canadian Association of Gastroenterology, CAG, Guideline Algorithm for the Management of Undiagnosed PUD. This is also the current management approach for patients with suspected PUD. TCA, tricyclic antidepressant. Adapted from Moe Yeti P., Lacey B., Andrews C.N., ETAL AC and CAG Clinical Guideline, Management of Dyspepsia. AMJ Gastroenterol 2017, 112:988-1013. Gisbert and Calvet 39 reviewed the literature and concluded that the HP test and treat strategy will cure most cases of PUD and prevent most cases of gastroduodenal disease. A small proportion of patients with HP-related functional dyspepsia would also improve in their symptoms. The test and treat strategy has been compared with endoscopy-directed diagnosis in 8 randomized controlled trials, RCTs. These trials differed in how HP was diagnosed, and the upper age cutoff varied from 45 to 55 years. In some studies, serology was used for diagnosis of infection, which is less specific than 1,3-C urea breath testing, see Chapter 52. The background HP prevalence in the study populations ranged from 23% to 53%. After a 12-month follow-up, the prevalence of dyspeptic symptoms was similar in the two groups. In 7 of the 8 trials, cost data were reported, and the test and treat strategy was less expensive because of the many endoscopies avoided. Ford and colleagues performed a meta-analysis of 5 RCTs involving 1924 patients and found a slight benefit at 12 months of prompt EGD on dyspeptic symptoms over test and treat, risk ratio, 0.95, 95% confidence index CI, 0.92 to 0.99, possibly because a normal EGD may have had a reassuring effect in some patients. 40 According to a joint AC/Canadian Association of Gastroenterology guidelines, it was recommended that patients with uninvestigated dyspepsia who are below 60 years of age should have a non-invasive test and treatment if positive. Those with a negative test or do not respond to this approach should receive a trial of PPI therapy. Tricyclic antidepressants or prokinetic therapies can be tried if they are not responsive to PPI therapy. The incidence of UGI malignancies including gastric cancer rises with age and, thus, current non-endoscopic management strategies are generally reserved for younger patients with upper abdominal symptoms. The age after which prompt EGD should become routine is debated and, to a substantial degree, depends on the epidemiology of UGI cancer in the population under consideration. In Western populations, UGI cancer is uncommon in young individuals, and therefore an age cutoff of 50 or 55 years is often used. Patients older than age 60 presenting with new onset upper abdominal symptoms suggestive of PUD should therefore be referred for EGD. In Asia and Eastern Europe, where the incidence of gastric cancer is substantially higher than in Western nations, a younger age cutoff may be reasonable. The Joint Act/Canadian Association of Gastroenterology Guidelines on Dyspepsia in 2017 recommended that patients with uninvestigated dyspepsia who are less than 60 years of age should have a non-invasive HP test and treatment if positive. 39,41 Those with a negative HP test or who do not respond to this approach should receive a trial of a PPI therapy. Tricyclic antidepressants or prokinetic therapies can be tried if the patients are not responsive to PPI therapy. See Chapter 14 and Fig 53.3. In areas of moderate to high HP prevalence, the test and treat strategy is preferred. The Maastricht Consensus Conference report in 2017 recommended a test and treat strategy for uninvestigated dyspepsia. This approach is subject to regional HP prevalence and cost-benefit considerations. 40,42 The test and treat strategy is, however, not applicable to patients with alarm symptoms or to older patients. The ability of alarm features, see box 53.1, to accurately predict malignancy, as opposed to PUD or non-ulcer dyspepsia, has, however, been questioned in a review of 15 studies. 43 The sensitivity of alarm symptoms in the diagnosis of malignancy varied from 0% to 83% across studies. Medical therapy of active peptic ulcer disease. Several pharmaceutical agents are available to attempt to heal active DUS and GUS. Pharmaceutical agents antacids neutralize gastric acid, but their ability to heal ulcers is poor. Most physicians do not use antacids as primary therapy to heal ulcers but instead recommend their use to relieve dyspeptic symptoms. The most common adverse effect of magnesium-containing antacids is diarrhea. In contrast, aluminum and calcium-containing antacids may cause constipation. All antacids must be used with caution, if at all, in patients who have chronic kidney disease, in whom magnesium-containing agents can cause hypermagnesemia, calcium-containing antacids hypercalcemia, and aluminum-containing antacid neurotoxicity. 44 Anti-secretory agents. Anti-secretory therapy is not routinely required for patients with uncomplicated HP ulcers in whom ulcers heal after successful eradication of HP even without anti-secretory therapy. However, anti-secretory drugs play an important role in the management of patients with PUD not associated with HP. The role of anti-secretory drugs in the management of gastrinoma, ZES, is discussed in Chapter 34. H2RAS are competitive inhibitors of histamine-stimulated acid secretion, see Chapter 51, and markedly suppress basal and meal-stimulated acid secretion. 45 When administered in the evening, H2RAS are effective in suppressing nocturnal acid output. 46 H2RAS are well absorbed after oral dosing, and their absorption is not affected by food. Peak blood levels are achieved within 1 to 3 hours after an oral dose. H2RAS cross the blood-brain barrier and the placenta. 47,48 After oral administration, several H2RAS, cimetidine, ranitidine, and famotidine, undergo first-pass hepatic metabolism, which reduces their bioavailability by 35% to 60%. In contrast, the H2RA-nizatidine does not undergo first-pass metabolism, and its bioavailability approaches 100% with oral dosing. H2RAS are eliminated by a combination of renal excretion and hepatic metabolism. Dose reductions are recommended when the creatinine clearance is below 50 ml/mi and dialysis does not remove substantial amounts of H2RAS, thus, dose adjustments are not necessary for dialysis patients. Dose reductions are generally not required for patients with hepatic failure unless it is accompanied by chronic kidney disease. Tolerance to the anti-secretory effects of H2RAS develops quickly and frequently. 49 Although the mechanism for tolerance is not clear, H2RAS are safe and well tolerated. One meta-analysis of randomized clinical trials concluded that the overall rate of adverse effects reported for H2RAS did not differ significantly from placebo treatment. 50 Nevertheless, a number of untoward effects have been described, primarily in anecdotal reports and uncontrolled series. Cimetidine has weak antiandrogenic activity that can occasionally cause gynecomastia and impotence. 51 Both cimetidine and ranitidine bind to the hepatic cytochrome P450, CYP, mixed function oxidase system. This binding can inhibit the elimination of other drugs that are metabolized through the same system, including warfarin, theophylline, phenytoin, lidocaine, and quinidine. 52 In contrast, famotidine and nizatidine have no significant avidity for the CYP system. PPIs. PPIs decrease gastric acid secretion through inhibition of H+, K+ ADPase, the proton pump of the parietal cell, see Chapter 51. These agents are prodrugs that must be activated by acid to inhibit the H+, K+ ADPase. Interestingly, prodrug PPIs are also acid-label compounds that must be protected from degradation by gastric acid after oral administration by enteric coating or an antacid. 53 Absorption of the enteric-coated PPIs may be erratic, and peak serum concentrations are not achieved until 2 to 5 hours after oral administration. Although the plasma half-life of PPIs is short, 2 hours, the duration of acid inhibition is long as a result of covalent binding of the active metabolite of the prodrug to the H+, K+ ADPase. PPIs undergo significant hepatic metabolism, but dose adjustments are not required in patients with significant renal or hepatic impairment. There is genetic polymorphism in CYP2C19, one of the isoenzymes involved in PPI metabolism. Approximately 25% of Asians and 3% of white persons have deficient CYP2C19 activity. This polymorphism leads to substantially higher plasma levels of omeprazole, lansoprazole, and pantoprazole, but not rabeprazole. 3637,54 PPIs, as a result of their requirement for concentration and activation in acidic compartments, bind predominantly to those proton pumps that are actively secreting acid. With meal stimulation, 60% to 70% of the proton pumps actively secrete acid, thus, PPIs are most effective if they are administered immediately before meals. For once-daily dosing, it is recommended that PPIs be taken immediately before breakfast. 55 Unlike H2RAS, tolerance to the anti-secretory effects of PPI therapy has not been seen. PPIs, by raising the gastric pH, can affect the absorption of a number of drugs. However, this pH effect rarely has clinically important effects, except when the PPIs are given with ketoconazole or digoxin. 55-57 Ketoconazole requires gastric acid for absorption, and this antifungal drug may not be absorbed effectively if PPIs have also been prescribed. If a patient requires both a PPI and antifungal therapy, it is recommended that an agent other than ketoconazole be chosen. Conversely, an elevated gastric pH facilitates absorption of digoxin, resulting in higher plasma digoxin levels. For patients treated concomitantly with PPIs and digoxin, clinicians should consider monitoring plasma digoxin levels. Because PPIs are metabolized by the CYP system, they have the potential to alter the metabolism of other drugs that are eliminated by CYP enzymes. The potential interaction between PPIs and clopidogrel has drawn widespread attention. Clopidogrel, a non-aspirin antiplatelet prodrug, is activated by hepatic CYP2C19 and other CYPs to its active metabolite. PPIs reduce the antiplatelet effect of clopidogrel through competitive inhibition of CYP2C19. Meta-analysis of observational studies reported a significant increase in major adverse cardiovascular events, including cardiovascular deaths among patients receiving concomitant PPIs and clopidogrel. 58,59 However, an association between PPI and clopidogrel use has not been confirmed by prospective studies and a large-scale RCT. 60,61 Despite the inconsistent findings, regulatory authorities in the USA and Europe have issued warnings against the use of certain PPIs in patients receiving concomitant clopidogrel. There are other concerns about the safety of long-term use of PPIs. To date, PPI use has been implicated in many conditions, including osteoporosis, hypomagnesemia, gastric cancer, enteric infections, interstitial nephritis, pneumonia, dementia, and NSAID enteropathy. Currently, there is no definite evidence to suggest that these conditions are attributable to PPI use. 62 It is possible that a new evidence will emerge to indicate a causal relationship. In the meantime, Long-term use of PPI without a strong indication should be discouraged. Potassium competitive acid blocker. Potassium competitive acid blocker, PCAB, therapy competes with potassium to inhibit H+, K+ ADPase in parietal cells at the final stage of the acid secretory pathway, see Chapter 51.63. Unlike PPIs, a PCAB is acid stable and does not require an acidic environment for activation, i.e., a prodrug is not required. To date, vonoprazan is the only PCAB commercially available in Japan and some other countries. Vonoprazan exerts a near maximum inhibitory effect from the first dose and its effect lasts for 24 hours. 63 In 2 phase 3 RCTs, vonoprazan, 20 mg once daily, was not inferior to lansoprazole, 30 mg once daily, for the healing of GUS and DUS. RCTs. 64,65 Two other randomized trials showed that vonoprazan, 10 and 20 mg, was as effective as lansoprazole, 15 mg, in preventing ulcer recurrence associated with long-term use of NSAIDs and low-dose aspirin. 66 Mucosal protective agents. Sucralfate is a complex aluminum salt of sulfated sucrose. When exposed to gastric acid, the sulfate anions can bind electrostatically to positively charged proteins in damaged tissue. 67,68 Sucralfate, 1 gram 4 times daily, is equally effective to H2RAS in healing DUS and is approved by the FDA in the USA for this indication. Very little, 5%, of sucralfate is absorbed owing to its poor solubility, and the drug is excreted via the enteral route. Because of its lack of systemic absorption, sucralfate appears to have no systemic toxicity. The effect on the accumulation of aluminum in the body has not been adequately studied in patients with chronic kidney disease treated with sucralfate, and sucralfate is best avoided in this population. Important drug interactions appear to be rare and can be avoided if sucralfate is administered at a time separate from other medications. Colloidal bismuth preparations, such as colloidal bismuth subcitrate and bismuth subsalicylate, e.g., Pepto-Bismol, have modest efficacy in healing peptic ulcers, but the mechanism is unclear. 69 The bismuth salts form complexes with mucus that appear to coat ulcer craters. Bismuth-induced increased mucosal prostaglandin synthesis and bicarbonate secretion have also been proposed. Bismuth salts have antimicrobial activity against HP, and bismuth has been approved in the USA by the FDA for use, in combination with other agents, for the treatment of HP infection, see Chapter 52. Bismuth is largely unabsorbed and excreted in the feces. Colonic bacteria convert bismuth salts to bismuth sulfide, which turns the stools black. Trace amounts of bismuth are absorbed in the UGI tract, with the bismuth then slowly excreted in the urine for 3 months or longer. Short-term, standard dose therapy with bismuth appears to carry little risk of toxicity. However, there is the potential for bismuth encephalopathy with neuropsychiatric symptoms if the agent is given for extended periods in high dosage, especially in patients with chronic kidney disease. Misoprostol is a prostaglandin E1 analog approved by the FDA for the prevention of NSAID-induced PUD. 70 The drug not only enhances mucosal defense mechanisms but also inhibits gastric acid secretion through inhibition of histamine-stimulated cyclic 3,5-cyclic adenosine monophosphate, AMP, production. 71 Well absorbed after oral administration, the plasma misoprostol concentration peaks after approximately 30 minutes, with a serum half-life of approximately 1.5 hours. The drug has no effect on hepatic CYP450. Misoprostol metabolites are excreted in the urine, but dose reductions are unnecessary in patients with chronic kidney disease. Dose-related diarrhea is the most common adverse effect, occurring in up to 30% of patients and limiting the usefulness of misoprostol. Diarrhea is related to prostaglandin-induced increases in intestinal electrolyte and water secretion and/or acceleration of intestinal transit time. Administration of misoprostol with food may reduce diarrhea. Misoprostol also stimulates uterine smooth muscle and is therefore contraindicated in women who may be pregnant. HP-associated ulcers. Treatment of HP infection is discussed in detail in Chapter 51, Tables 51.2 and 51.3. It is well established that curing HP infection not only heals peptic ulcers but also prevents ulcer relapses and complications. 72-75 Because HP infection accounts for 80% to 90% of DU cases, testing for the infection in patients with DU is mandatory. If the diagnosis of DU is made endoscopically, gastric biopsy specimens should be taken to detect HP infection. There is good evidence that a 10 to 14-day course of HP eradication therapy is sufficient to heal DUS such that additional anti-secretory therapy is not usually required. Follow-up endoscopic examination in order to document healing and perform testing to document HP eradication following antibiotic therapy is not recommended routinely in patients with uncomplicated DUS. However, non-invasive tests such as the urea breath test can be used to confirm HP eradication. Whether anti-secretory therapy is required after a 7 to 14-day course of HP eradication therapy in patients with GU is somewhat controversial. 1 week of antibacterial therapy without acid suppression effectively heals HP-related GUS. 72 In a meta-analysis of GU healing trials, treatment with HP eradication therapy produced similar outcomes to treatment with an ulcer healing drug. 73 However, in patients with large or complicated GUS, additional anti-secretory therapy can facilitate ulcer healing. Follow-up endoscopy is recommended in patients with large or complicated GUS to document healing, exclude malignancy, and confirm successful HP eradication. NSAID ulcers H2RAS Conventional doses of H2RAS are more effective in healing NSAID-related DUS than GUS. There are limited data on the efficacy of H2RAS in healing peptic ulcers if patients continue to receive NSAIDs. Therefore, H2RAS are not preferred agents in patients with ulcers who require uninterrupted NSAID therapy. PPI's current evidence 76-78 indicates that PPIs are superior to standard dose H2RAS in healing NSAID-induced peptic ulcers. In a randomized comparison of esomeprazole, 20 or 40 mg/day, and ranitidine, 150 mg twice daily, in ulcer patients who continued to take NSAIDs, ulcer healing at 8 weeks occurred in 85% and 86% of patients given esomeprazole and in 76% of those given ranitidine. 78 In another study of patients with NSAID-associated GUS who continued to use NSAIDs, ulcer healing at 8 weeks occurred in 69% and 73% of patients given lansoprazole, 15 or 30 mg/day, but in only 53% of those given ranitidine, 150 mg. Twice daily. 77 Misoprostol in ulcer patients who continued their NSAID, misoprostol healed the ulcers in 67% of patients at 8 weeks, compared with only 26% of patients treated with placebo. 79 However, misoprostol is not as effective as PPI therapy in healing NSAID-associated ulcers. One randomized trial compared full-dose misoprostol, 200 mg 4 times daily, with omeprazole, 20 or 40 mg daily, in DU or GU patients who continued NSAID treatment. 80 After 8 weeks, DUS had healed in 89% of patients receiving either dose of omeprazole and in 77% of those receiving misoprostol. Similarly, GUS had healed in 87% of those receiving 20 mg of omeprazole, 80% of those receiving 40 mg of omeprazole, and 73% of those receiving misoprostol. Although misoprostol is seldom used for treatment or prevention of peptic ulcer nowadays, 2 randomized trials have shown that misoprostol is effective for the healing of small bowel ulcers and erosions in patients with obscure bleeding taking NSAIDs and low-dose aspirin. 81-82 Other causes of ulcers and idiopathic ulcers. When the cause of a peptic ulcer can be identified as other than HP or NSAID use, e.g., gastrinoma, the underlying disorder should be treated. See Chapter 34. The treatment of idiopathic, non-HP, non-NSAID ulcers relies on acid anti-secretory therapy, usually a PPI, which is often given long-term, maintenance therapy, much as anti-secretory therapy is used long-term to prevent NSAID-induced ulcers in moderate and high-risk patients, see later. Refractory ulcers. Most peptic ulcers heal within 8 weeks of initiation of anti-secretory therapy. Nevertheless, in a small but considerable minority of patients, the ulcers persist despite conventional treatment. Such ulcers can be considered refractory. There is no standardized definition for refractory peptic ulcer, making comparisons among studies difficult. In some patients with refractory ulcers, symptoms of ulcer disease persist and may be severe. In others, the refractory ulcer becomes asymptomatic and is only detected at endoscopy, e.g., at the 8-week follow-up endoscopy to assess healing of a GU. For the patient whose ulcer does not heal despite a trial of conventional therapy, the clinician should ask the following questions: has the patient complied with the prescribed treatment? Is the ulcer penetrating the pancreas, liver, or other organ? Is there HP infection? If antibiotic therapy had already been prescribed, the patient should be tested to confirm that the infection has indeed been eradicated. If no attempt had been made to diagnose and treat HP infection, it should be made now. False negative test results for HP should be considered, see Chapter 52. Is the patient still taking an NSAID? NSAID use may be surreptitious. A careful history regarding the use of over-the-counter NSAIDs, including low-dose aspirin, should be obtained, and NSAIDs should be stopped if possible. Does the patient smoke cigarettes? If so, he or she should be counseled strongly to discontinue cigarettes. Has the duration of ulcer treatment been adequate? Large ulcers require a longer duration of therapy than small ulcers to heal. A large ulcer, e.g., greater than 2 cm, probably should not be considered refractory until it has persisted beyond 12 weeks of anti-secretory therapy. Is there evidence of a hypersecretory condition? A family history of gastrinoma or men type I, or a personal history of chronic diarrhea, hypercalcemia caused by hyperparathyroidism, or ulcers involving the postbulbar duodenum or proximal jejunum suggest a diagnosis of ZES, see Chapter 34. Finally, is the ulcer indeed peptic? Primary or metastatic neoplasms, infections, e.g., cytomegalovirus, cocaine use, eosinophilic gastroenteritis, and Crohn's disease can cause ulcerations of the stomach and duodenum that can mimic peptic ulcers. These disorders should be considered and excluded appropriately. Treatment options for truly refractory peptic ulcers include a more prolonged course of anti-secretory therapy, often at double the prior PPI dose. Although uncommon nowadays, elective ulcer surgery may be necessary to attempt to heal a symptomatic refractory or penetrating ulcer. Surgical options are discussed later in this chapter. Prevention of ulcer disease. Most studies of ulcer prophylaxis have used endoscopy endpoints, rather than clinical endpoints, to assess the effectiveness of various regimens. An endoscopic ulcer has been arbitrarily defined as a circumscribed mucosal defect having a diameter of 5 mm or more with a perceivable depth 0.83. However, many studies have loosened this criterion to include flat mucosal breaks with a diameter of 3 mm or more as ulcers. The distinction between small ulcers and erosions is arbitrary and is prone to interobserver bias. The clinical relevance of these minor endoscopic lesions is uncertain. It is assumed that endoscopic findings roughly correlate with clinical outcomes in subjects at low to average risk for ulcer complications. It is unclear if results of endoscopic studies can be generalized to high-risk patients. Because there are few prospective outcome trials to evaluate the true clinical efficacy of ulcer prophylactic agents, clinical judgment relies on data largely using endoscopic endpoints. HP ulcers do not require ulcer prophylaxis if the organism can be eradicated from the stomach, see earlier in Chapter 52. Most use of ulcer prophylaxis regimens is, therefore, related to prevention of NSAID ulcers in patients at moderate to high ulcer risk. The risk factors for NSAID-induced ulcers are listed in Table 53.1. Pharmaceutical agents that may reduce the development of NSAID-induced ulcers are discussed later. Ulcer prophylaxis is also frequently used in patients with idiopathic ulcers. Among the agents listed, only the anti-secretory agents are commonly used in the prevention of idiopathic ulcers. Antacids. Many clinicians prescribe antacids as CO therapy for patients taking NSAIDs, both to relieve dyspeptic symptoms and to, hopefully, prevent ulcers. However, Antacids have no proved efficacy. Table 53.1 Risk factors for NSAID ulcers * risk factor risk ratio history of complicated ulcer 13.5 Use of multiple NSAIDs, including aspirin, COX-2 inhibitors, 9 Use of high doses of NSAIDs 7 Use of an anticoagulant 6.4 History of an uncomplicated ulcer 6.1 Age greater than 70 years 5.6 HP Infection 3.5 Use of a glucocorticoid 2.2 * Not all NSAIDs pose the same risk. In the prevention of NSAID-induced ulcers, antacids may mask dyspeptic symptoms, thereby creating a false sense of ulcer protection and increasing the risk of silent ulcer complications with prolonged NSAID therapy. CO prescription of antacids in patients taking NSAIDs who are at risk for ulcer should be discouraged. H2RAS Using standard doses of H2RAS is not effective in preventing NSAID-induced GUS 84,85 and, as already mentioned, may be harmful. A systematic review 85 of randomized trials in NSAID users concluded that using twice the standard daily dose of H2RA significantly reduces the risk of endoscopic NSAID-induced DUS and GUS. However, whether high-dose H2RAS prevent NSAID-induced ulcer complications is unknown. In contrast, H2RAS appear to be more effective for prevention of ulcers associated with low-dose aspirin than with NSAIDs. In a 12-month, multi-center randomized trial of low-dose aspirin users at risk for recurrent ulcer bleeding, there was no significant difference in the incidence rates of recurrent bleeding between patients receiving a PPI and patients receiving an H2RA. 89 Misoprostol The efficacy of misoprostol in preventing NSAID-induced ulcers has been assessed in RCTs. 86,87 A systematic review of these trials indicated that all doses of misoprostol studied, 400 to 800 μg/day, reduce the risk of NSAID-induced endoscopic ulcers. 85 However, only full-dose misoprostol, 800 μg/day, reduces ulcer complications. 86 In a randomized double-blind trial in patients with rheumatoid arthritis who received NSAIDs, misoprostol, 200 μg 4 times daily, lowered the rate of GI complications by 40%, from 0.95% in the placebo group to 0.57% in the misoprostol group. However, up to 30% of misoprostol-treated patients in this trial experienced GI upset, thereby limiting its clinical use. Even though endoscopic studies had suggested that lower doses of misoprostol, such as 200 μg 2 or 3 times daily, can prevent NSAID-induced ulcers with fewer adverse effects than the full dose. 86 Such low doses of misoprostol fail to prevent ulcer complications. 88 PPIs significantly reduce the risk of endoscopic duodenal and GUS. 85 The efficacy of PPIs has been compared with that of H2RAS and with misoprostol in patients who received NSAIDs. Two 6-month studies compared omeprazole 20 mg once daily with either standard dose ranitidine, 150 mg twice daily, and half-dose misoprostol, 200 μg twice daily. 0.76,80 Omeprazole was more effective than standard dose ranitidine and comparable with half-dose misoprostol in preventing endoscopic ulcers. The superiority of omeprazole over ranitidine in preventing NSAID-related ulcer was due to a greater reduction in endoscopic DUS. A post-hoc analysis revealed that most of the added protection attributable to omeprazole over ranitidine occurred among those with HP infection. Another endoscopic study compared high-dose misoprostol, 200 μg 4 times daily, with 2 doses of lansoprazole, 15 and 30 mg daily, for the prevention of ulcers in long-term NSAID users without HP infection and with a history of GU. 88 Misoprostol was more effective than either dose of lansoprazole in preventing GU, but there was no practical advantage of misoprostol over lansoprazole because of the high withdrawal rate in the misoprostol group. In a head-to-head endoscopic ulcer prevention study comparing 2 doses of pantoprazole with 20 mg/day of omeprazole in patients with rheumatoid arthritis receiving NSAIDs, the 6-month probabilities of remaining ulcer-free were 91%, 95%, and 93% for pantoprazole 20 mg, pantoprazole 40 mg, and omeprazole 20 mg, respectively. 89. Two identical multi-center randomized clinical trials compared esomeprazole, 20 or 40 mg, with placebo in the prevention of ulcers in patients taking NSAIDs or COX-2 inhibitors over a 6-month period. Patients in both studies were HP negative, older than age 60, and had a history of GU or DU overall. The rates of ulcers were 17.0%, 5.2%, and 4.6% in the groups receiving placebo, esomeprazole 20 mg, and esomeprazole 40 mg, respectively. 90. Whether PPIs can reduce the risk of NSAID-associated peptic ulcer bleeding is largely based on observational studies and one randomized trial in high-risk patients. A large-scale, case control study found that PPI therapy was associated with a significant reduction in risk of UGI bleeding among chronic NSAID users. Relative risk, 0.13, 95% CI, 0.09 to 0.19. 0.91. The randomized trial compared long-term, 6 months, omeprazole therapy to 1 week of HP eradication therapy for the prevention of recurrent ulcer bleeding in HP-infected patients with a recent history of NSAID-related ulcer bleeding who continued to use naproxen. 92. Recurrent ulcer bleeding occurred in 18.8% of patients undergoing eradication therapy compared with only 4.4% of patients receiving omeprazole. COX-2 inhibitors, in place of NSAIDs, COX-2 inhibitors offer the hope of minimizing GI toxicity of NSAIDs while preserving their therapeutic effects. 93-97. In a systematic review of randomized trials, when compared with non-selective NSAIDs, the COX-2 inhibitors led to significantly fewer gastroduodenal ulcers. Relative risk, 0.26, 95% CI, 0.23 to 0.30, and ulcer complications, relative risk, 0.39, 95% CI, 0.31 to 0.5, as well as fewer withdrawals caused by GI symptoms. 94. However, the sparing effect of COX-2 inhibitors on ulcer development is negated by concomitant use of low-dose aspirin. 59. Current evidence indicates that COX-2 inhibitors are as effective as a combination of non-selective NSAIDs combined with a PPI in patients at risk for ulcers. In a randomized comparison of the NSAID diclofenac plus omeprazole versus celecoxib for secondary prevention of ulcer bleeding in patients who either were HP negative or had undergone HP eradication. 95. A similar proportion of patients had recurrent bleeding in 6 months, 6.4% in the diclofenac/omeprazole group and 4.9% of patients in the celecoxib group. Although the two treatments were comparable in terms of the incidence of ulcer bleeding, a subsequent follow-up endoscopic study showed that 20% to 25% of patients receiving either treatment developed recurrent endoscopic ulcers at 6 months. These findings suggest that neither treatment can eliminate the risk of recurrent bleeding in very high-risk patients. In a 13-month, double-blind randomized trial comparing celecoxib alone with celecoxib/esomeprazole in patients with a history of NSAID-associated ulcer bleeding, 8.9% of the celecoxib alone group had recurrent ulcer bleeding compared with none of the combined therapy group, p equals 0.0004, 0.96. Despite the improved gastric safety profile of COX-2 inhibitors, the cardiovascular risk associated with this new class of NSAIDs has been a subject of much concern. In the VIGOR study 97, the incidence of acute myocardial events, although low, was 4 times higher among patients receiving rofecoxib than among patients receiving naproxen. Whether this observed difference in myocardial infarction rates was related to an antiplatelet property of naproxen or to a prothrombotic effect of rofecoxib was debated. Further data regarding the cardiovascular hazards of COX-2 inhibitors were derived from 2 long-term studies of colon polyp prevention, using either rofecoxib, the adenomatous polyp prevention on Vioxx-approved study, 98, and celecoxib, the adenoma prevention with celecoxib APC study, 0.99 in approve. Interim data at 18 months indicated that patients who had received 25 mg rofecoxib a day had twice the risk of serious cardiovascular events compared with patients who received placebo. In 2004, rofecoxib was voluntarily withdrawn from worldwide markets in light of this unexpected finding. In the APC study, interim data at 33 months showed that serious cardiovascular events were significantly more frequent with selexipag at the high dose of 400 mg twice a day, hazard ratio, 1.9, 95% CI, 1 to 3.3. The MEDAL program was a pre-specified pooled analysis of cardiothrombotic events from 3 trials in which patients with osteoarthritis or rheumatoid arthritis were randomly assigned to etorixib, 60 mg or 90 mg daily, or diclofenac, 150 mg daily. After an average treatment of 18 months, rates of cardiothrombotic events were similar between the 2 treatment groups. 100 Table 53.2 Recommendations for reducing the risk of NSAID ulcers as a function of GI and cardiovascular risk. GI risk * low moderate high low CV risk NSAID at the lowest effective dose NSAID plus a PPI, or selexipag alone selexipag plus a PPI high CV risk naproxen or selexipag, plus a PPI naproxen or selexipag, plus a PPI selexipag plus a PPI if simple analgesics failed. * low GI risk denotes no risk factors, see Table 53.1, moderate GI risk denotes 1 or 2 risk factors, high GI risk denotes greater than or equal to 3 risk factors, prior complicated ulcer, or concomitant use of low-dose aspirin or anticoagulants. All patients with a history of ulcer who require NSAIDs should be tested for HP, and if infection is present, eradication therapy should be given, see Chapter 52. High CV risk denotes the requirement for prophylactic low-dose aspirin for primary or secondary prevention of serious CV events. CV, cardiovascular. Current evidence suggests that not only COX-2 inhibitors but also non-selective NSAIDs, with the exception of full-dose naproxen, 1000 mg/day, increase cardiothrombotic risk. In a meta-analysis of randomized trials of COX-2 inhibitors, data mostly derived from rofecoxib and selexipag, all COX-2 inhibitors increased the cardiothrombotic risk compared with placebo, risk ratio, 1.42, 95% CI, 1.13 to 1.78. This was largely attributable to an increased risk of myocardial infarction, with little difference in other vascular outcomes. A dose-dependent increase in cardiothrombotic events was observed with selexipag. Importantly, there was no significant difference in cardiothrombotic risk between COX-2 inhibitors and non-selective NSAIDs, with naproxen, 500 mg twice daily, the only exception. In a meta-analysis of observational studies, high-dose rofecoxib, greater than or equal to 25 mg a day, diclofenac and indomethacin were associated with an increase in cardiothrombotic events, whereas selexipag did not significantly increase the cardiothrombotic risk, although an increased risk could not be excluded with doses greater than 200 mg/day. 101 In a large-scale, randomized, non-inferiority trial of selexipag versus naproxen and ibuprofen in patients with arthritis, mostly osteoarthritis, and with increased cardiovascular risk 102 more than 24,000 patients were recruited with a mean treatment duration of 20 months and a mean follow-up period of 34 months. Selexipag, on average approximately 200 mg/day, was found to be non-inferior to ibuprofen, approximately 2000 mg/day, or naproxen, approximately 850 mg/day, with regard to cardiovascular safety. Patients treated with selexipag had a significantly lower risk of adverse GI events than with naproxen or ibuprofen. The risk of adverse renal events was also significantly lower with selexipag than with ibuprofen. However, the proportion of patients continued on concomitant low-dose aspirin during the study period was unclear and very few patients had a history of GI bleeding. It is, therefore, unclear whether the advantage of selexipag over naproxen or ibuprofen can be extrapolated to patients on concomitant aspirin with high risk of GI bleeding. In another 18-month randomized trial of patients at high risk of both cardiovascular and GI adverse events who required concomitant low-dose aspirin and an NSAID, selexipag plus a PPI was found to be superior to naproxen plus a PPI in reducing the risk of recurrent ulcer bleeding. 103, 108 Assessing risk and choice of agent, S. safe prescription of NSAIDs should be based on assessment of an individual patient's GI and cardiovascular risks. In patients with low cardiovascular risk, the therapeutic approach can be stratified according to their levels of GI risk as follows. Table 53.2 Low ulcer risk, no risk factors. Patients without risk factors, see Table 53.1, are at very low risk of ulcer complications with NSAID use, 1% per year. Rational use of NSAIDs, including avoidance of high doses of NSAIDs and use of a less ulcerogenic NSAID, e.g., ibuprofen, diclofenac, at the lowest effective dose is a cost-effective approach. Moderate ulcer risk, 1 or 2 risk factors. These patients should receive combination therapy with an anti-ulcer agent, a PPI or misoprostol, and an NSAID. Alternatively, substitution with celecoxib alone is as effective as the combination therapy mentioned earlier. High ulcer risk, 3 or more risk factors, history of ulcer complications, or concomitant use of low-dose aspirin, glucocorticoids, or anticoagulant therapy. In general, NSAIDs should be avoided in these patients, not only because of the high risk of ulcer complications but also owing to the serious consequences of ulcer complications in the presence of comorbidities. Glucocorticoid therapy, without NSAID, can be considered if short-term anti-inflammatory therapy is required for acute, self-limiting arthritis, e.g., gout, because glucocorticoids alone do not increase the risk of ulcer. If regular anti-inflammatory therapy is required for chronic arthritis, the combination of celecoxib and a PPI offers the best GI protection. Defining patients with high cardiovascular risk remains arbitrary. The American Heart Association recommends that aspirin should be considered in all apparently healthy men and women whose 10-year risk for a cardiovascular event is 10% or above. 104 We consider patients with arthritis to have significant cardiovascular risk if they are already on aspirin for secondary prophylaxis or if they require aspirin for primary prophylaxis according to the American Heart Association guidelines. Because the potential cardiovascular hazards of COX-2 inhibitors and most non-selective NSAIDs, patients with high cardiovascular risk should avoid using these drugs, if possible. Ibuprofen can attenuate the cardioprotective effect of aspirin, possibly through competitive binding to platelet COX-1, and concomitant use of ibuprofen and low-dose aspirin, therefore, should be avoided. If an NSAID is deemed necessary in patients at high cardiovascular risk, current evidence suggests that either celecoxib at moderate dose, 200 mg/day, or naproxen can be considered. One major drawback of concomitant use of NSAIDs such as naproxen and low-dose aspirin is that the combination will markedly increase the risk of ulcer complications, thus, combination of celecoxib and low-dose aspirin may be the best available option for patients with high GI and high cardiovascular risk who require NSAIDs for long-term. Because HP infection increases the risk of ulcer complications in NSAID users, patients with a history of PUD who require NSAIDs for long-term should be tested for HP and, if present, the infection should be eradicated. Complications and their treatment. Bleeding. Acute UGI bleeding, the most common complication of PUD, is discussed in detail in Chapter 20. PUD remains the leading cause of acute UGI bleeding. 105 Consensus groups have recommended a multidisciplinary approach to the care of patients presenting with UGI bleeding. 106 Patients with acute UGI bleeding should be assessed promptly on presentation. Volume resuscitation should take priority and precede endoscopy. Features of liver disease should call attention to the possibility of bleeding from esophagogastric varices rather than an ulcer. This distinction has prognostic as well as management implications. Variceal hemorrhage carries a higher death rate than ulcer bleeding. The possibility of variceal hemorrhage calls for specific measures prior to endoscopy, such as the use of vasoactive drugs, e.g., octreotide, and antibiotics, e.g., cefotaxime, as prophylaxis against infective complications such as spontaneous bacterial peritonitis. See chapters 92 and 93. Endoscopic therapy. Early endoscopy is generally defined as EGD performed within 24 hours of the patient's admission. In patients with signs of active UGI bleeding, urgent endoscopy establishes a diagnosis and offers a possible intervention. RCTs demonstrated that early endoscopy in patients at low risk for rebleeding allowed early hospital discharge, reduced resource utilization, and facilitated management as outpatients. 107-109 Meta-analysis of 18 clinical trials that compared endoscopic therapy to pharmacotherapy alone showed that endoscopic therapy was superior with regard to the rates of further bleeding, odds ratio or 0.35, 95% CI, 0.27 to 0.46, surgery, or 0.57, 95% CI, 0.41 to 0.81, and, importantly, mortality, or 0.57. 95% CI, 0.37 to 0.89. 110 An international consensus GROUP 104 recommended the use of a prognostic score to guide patient management. The Rock-Hall scoring system is a composite score using pre- and post-endoscopy clinical parameters to predict mortality. The score was derived from data gathered from the first national UK audit. 109 The Glasgow-Blatchford score, GBS, on the other hand, uses only clinical parameters to predict the need for intervention and is calculated from patients' hemoglobin level and blood urea concentration, pulse, and systolic blood pressure on admission, the presence or absence of melena or syncope, as well as evidence of cardiac or hepatic failure. 110 The GBS has been the most widely validated score and correlates with clinical outcomes. In a multi-center prospective STUDY 111 of 3,012 patients, the GBS score was the best of the four at predicting the need for intervention or death with an area under the receiver operating curve, AROC, of 0.86. A GBS score of 1 appears to be the threshold for outpatient management. The GBS score, however, does not define a cutoff value above which urgent endoscopy becomes mandatory. A significant proportion of patients at low to median scores require endoscopic treatment. At the time of EGD, endoscopic stigmata of bleeding in an ulcer not only pinpoint PUD as the source of bleeding but are themselves prognostic for patient outcomes. See Chapter 20. The commonly used nomenclature is a version modified from Forrest and Finlayson S112 original description. Lane and Jensen 113 summarized rates of further bleeding, surgery, and mortality associated with stigmata of bleeding in prospective trials without endoscopic therapy. Type I, active bleeding, IA, spurting hemorrhage, Fig 53.4, IB, oozing hemorrhage, see Fig 53.4, Type 2, stigmata of recent hemorrhage, IIA, non-bleeding visible vessel, see Fig 53.4, IIB, adherent clot, see Fig 53.4, IIC, flat pigmentation, see Fig 53.4, Type 3, clean base ulcers, actively bleeding ulcers and ulcers with non-bleeding visible vessels, protuberant discoloration or a sentinel clot, warrant endoscopic therapy, see Chapter 20. Endoscopic therapy of ulcers with adherent clots had been controversial. The definition of adherent clot varies with the vigor in endoscopic washing. Two randomized controlled studies 114,115 and a meta-analysis 116 compared medical therapy to endoscopic treatment in ulcer patients with adherent clots and concluded that clot removal followed by endoscopic treatment of the vessel underneath lowers the risk of recurrent bleeding from 30% to 5%. The term sentinel clot is often used synonymously with visible vessel. 117 It represents a fibrin clot, which plugs the rent in an eroded artery. As the ulcer begins to heal, the clot resolves, leaving a flat pigmentation to the ulcer base, which eventually disappears from the ulcer floor. This evolution of a bleeding vessel usually takes less than 72 hours. Ulcers with a flat pigmentation or a clean base do not warrant endoscopic therapy. Recently, a group from UCLA reported their experience with the use of an endoscopic Doppler probe to interrogate the ulcer base. In a prospective cohort of 163 patients with bleeding ulcers and varying endoscopic stigmata or recent hemorrhage, Doppler signals were found in ulcers with minor stigmata, adherent clots, 68.4%, and flat pigmentations, 40.5%, 118 in a subsequent RCT of 148 patients with bleeding peptic ulcers, Jensen and Associates 119 compared Doppler endoscopic probe-guided hemostasis to standard endoscopic hemostasis. The 30-day rebleeding rate was lower with the use of a Doppler probe to guide the treatment endpoint, 11.1% versus 26.3%, p equals 0.02. Endoscopic therapeutic modalities are discussed in more detail in Chapter 20, and the methods used are discussed briefly here. Injection methods: Fig. 53.4 Endoscopic appearances of bleeding peptic ulcers using the Forest classification. 139 Endoscopic injection of diluted epinephrine into a bleeding peptic ulcer works by volume tamponade and local vasoconstriction. The technique is easy to learn and is not damaging to tissues. Diluted epinephrine, however, does not induce vessel thrombosis. Recurrent bleeding after injection with diluted epinephrine alone occurs in 20% to 30% of patients. Injection with diluted epinephrine allows a clear view of the bleeding vessel and should then be combined with application of either thermal coagulation or clips. In a meta-analysis, 120 addition of a second modality after epinephrine injection significantly reduced the rate of recurrent bleeding, RR 0.57, 0.43 to 0.76, emergency surgery, RR 0.68, 0.5 to 0.93, and mortality, RR 0.64, 0.39 to 1.06. Improved outcomes seem to be more evident in ulcers with active bleeding, Forest type I ulcers. Injection with diluted epinephrine alone should no longer be considered an adequate treatment. A second treatment to induce arterial thrombosis should be added. Thermal methods include contact and non-contact methods. Contact thermal methods are more often used. Commonly used contact thermal probes are the heater probe and bipolar probes. The term coaptive thermal coagulation emphasizes the need for firm mechanical compression of the vessel. Cessation of blood flow by compression reduces the heat sink effect when heat energy is generated, welding the arterial lumen. The main non-contact method is argon plasma coagulation, see Chapter 20. Mechanical methods: the mechanical method of hemoclipping is widely used. Tangential applications of clips in treating bleeding posterior duodenal bulbar or lesser curvature ulcers with the endoscope in a retroflexed position can be technically difficult. In meta-analyses comparing endoscopic treatment modalities, hemoclips was superior to injection alone in rate of hemostasis and comparable to thermal coagulation. 108,121 Recently, a multi-center RCT compared the use of over-the-scope clips, OTSC, to standard through-the-scope clips and thermal methods in 66 patients with refractory bleeding ulcers. 122 The use of OTSC was associated with a reduced rate of further bleeding, 15.2% versus 57.6%. OTSC are made of shape memory nitinol of up to 13 mm in diameter capable of strong tissue compression over a wider area. The current standard is the use of either through-the-scope hemoclips or thermal coagulation with or without pre-injection of epinephrine. OTSC appears to be a useful rescue when other modalities fail. Anti-secretory therapy: the rationale for anti-secretory therapy in bleeding PUD is based on the fact that both pepsin activity and platelet aggregation are pH dependent. An ulcer stops bleeding when a fibrin or platelet plug blocks the rent in a bleeding artery. When gastric pH exceeds 4, pepsin is inactivated, preventing enzymatic digestion of blood clots. A gastric pH of 6 or greater is critical for clot stability and hemostasis. Lebens and Associates 123 studied gastric pH in patients with GU or DU who were receiving either a high dose of omeprazole, 4 bolus 80 mg, followed by 8 mg/hr, or a high dose of ranitidine, 4 bolus 50 mg, followed by 0.25 mg/kg/hr. The gastric pH exceeded 6 with omeprazole 99.9% of the time, but less than 50% of the time in patients receiving ranitidine, 46% of the time in GU patients and 20% of the time in DU patients. The PUB study was an international multi-center study that enrolled 764 patients with ulcer bleeding. It evaluated use of high-dose esomeprazole after endoscopic hemostasis in bleeding peptic ulcers. The PPI reduced the rate of recurrent bleeding over 30 days from 11.6% to 6.4%. In addition, fewer patients given the PPI needed further endoscopic therapy, blood transfusion, and surgery. 124 A Cochrane's systematic review of randomized trials that compared PPI use to placebo or H2RA concluded that the use of PPI therapy significantly reduces rates of recurrent bleeding and surgery but not overall mortality. 125 In a subgroup analysis among patients with active bleeding or with a non-bleeding visible vessel, a significant reduction in mortality was observed with use of PPI. Or 0.53, 95% CI, 0.31 to 0.91. The optimal PPI dose to use and the routine of PPI administration continue to be controversial. A meta-analysis of RCTs that compared low to high-dose PPI use after endoscopic hemostasis consisted of trials that included bleeding ulcers with minor stigmata of bleeding and clean-based ulcers. 126 The majority of studies were underpowered to declare equivalence between low and high-dose PPI. An international consensus group has continued to endorse the use of a high-dose PPI, especially in high-risk patients. 104 Preemptive use of an 4-PPI infusion prior to endoscopy was studied in a large-scale randomized study. 127 Patients with overt signs of UGI bleeding were randomized to receive either a high-dose PPI infusion or placebo. Most, 60%, of the patients in this cohort were found at EGD to be bleeding from a peptic ulcer. The study demonstrated that early PPI infusion downstaged endoscopic bleeding stigmata in patients with peptic ulcers and thereby reduced the need for endoscopic therapy. Thus, there were fewer ulcers with active bleeding or with major stigmata of recent hemorrhage observed during the following morning's EGD in the PPI group. PPI infusion starts ulcer healing, and significantly more clean-based ulcers are seen the next day. The study has cost-saving implications, with less endoscopic therapy required with the preemptive use of an 4-PPI. In patients awaiting endoscopy, it is reasonable to start PPI therapy. Surgical therapy, effective endoscopic intervention and improved pharmacotherapy have greatly reduced the need for emergency ulcer surgery. In the USA, the incidence of surgery to control ulcer bleeding has continued to decline, from 13.1% in 1993 to 9.7% in 2006, while there was an increase in the use of endoscopic treatment, 12.9% to 22.2%. 128 In a UK national audit in 2006, only 2.3% of 4,478 patients who presented with UGI bleeding required surgery. Mortality after surgery was 29%. 129 Surgery is indicated in patients with bleeding not controlled during endoscopy or with further bleeding refractory to endoscopic therapy. Independent predictors to recurrent bleeding after endoscopic hemostatic therapy include hemodynamic instability, comorbid illnesses, active bleeding at endoscopy, large ulcer size, posterior due or lesser curvature ulcer. 130 Often, an attempt at further endoscopic control is indicated. A RCT that compared endoscopic retreatment to surgery suggested that the former can secure bleeding in 75% of cases and is associated with less procedure-related morbidities. 131 The type of emergency operation to be performed for ulcer bleeding is controversial. Some surgeons maintain that oversewing of ulcers alone, combined with acid suppression therapy, is safer than definitive surgery using either gastrectomy or vagotomy. HP eradication and PPIs have provided incentives for surgeons to perform the minimum operation. 2 RCTs that compared minimal with definitive surgery were published before the era of endoscopic hemostasis and PPI infusion. 132,133 A UK multi-center study compared minimal surgery, oversewing the vessel or ulcer excision alone plus 4H2RA therapy, with the definitive ulcer operation, vagotomy and pyloroplasty or partial gastrectomy, in patients with bleeding GUS or DUS. The trial was aborted because of the high rate of fatal recurrent bleeding in those assigned to minimal surgery, 7 in 62 patients, with 6 deaths. Of the 67 patients who received definitive ulcer surgery, 4 rebled and none died. 132 In a trial conducted by the French Association of Surgical Research, patients with DU were randomized to receive oversewing plus vagotomy and drainage or partial gastrectomy. 133 After oversewing and vagotomy, recurrent bleeding occurred in 10 of 60 patients, 17%. Conversion to a Bill 2 gastrectomy was required in 6 of the 10 patients with recurrent bleeding. In the group of 60 patients assigned to undergo partial gastrectomy, only 3% had rebleeding, and both recovered with conservative treatment. With an intention to treat analysis, no differences in overall mortality rates or duodenal leak rates were seen. These two RCTs suggest that simple oversewing with or without vagotomy is associated with a higher rate of recurrent bleeding. Exclusion of an ulcer or, in the case of GUS, ulcer excision is important in preventing recurrent bleeding. In a review of data from the American College Surgeons National Surgical Quality Improvement Program, 30-day mortality was higher in patients who underwent a simple oversewing or ulcer excision, 106/498, 21.3%, when compared to that after vagotomy with resection or drainage, 39/283, 13.8%. There was obvious bias in this retrospective analysis. 134 Angiographic therapy. Angiographic embolization of bleeding arteries is a non-operative alternative to surgery in patients with bleeding peptic ulcer. In a pooled analysis of 6 retrospective studies comparing angiography and surgery, a higher rebleeding rate was observed after angiographic treatment, 51/178, or 29% versus 36/241, or 15%, RR 1.82, 95% CI, 1.20 to 2.67, 0.135 mortality was not significantly different, 17% versus 23%. When radiology skills are available, angiography is often attempted before surgery. A recent RCT that compared added embolization to standard treatment after endoscopic hemostasis did not confirm a mortality benefit of prophylactic embolization. 136 In a per-protocol analysis, rate of further bleeding was lower after added embolization, 6/96, or 6.2% versus 14/123, or 11.4%. In a subgroup analysis of ulcers of 15 mm or more in size, embolization reduced bleeding from 23.1% to 4.5%. The authors suggested that for larger ulcers with significant bleeding, angiographic embolization should be considered after endoscopic hemostasis. Perforation of a GU or DU, Fig 53.5, is a surgical emergency that may be the initial manifestation of PUD, especially in patients using NSAIDs. Ulcer perforation is associated with a mortality approaching 30%. Older adults with significant comorbid illnesses and a delay in performing surgery have the worst prognosis. The clinical presentation is one of peritonitis, but clinical signs can be obscured in older and immunocompromised patients. See Chapter 39. Medical therapy. It has been suggested that a standardized perioperative management protocol can improve outcomes. In a Danish multi-center study, N equals 2619, 137, the PULP trial group showed that with aggressive and specific treatment of sepsis and, importantly, Fig 53.5 laparoscopic view of a perforated DU, arrow, with fibrinous exudate on the adjacent peritoneum. Surgery within 6 hours. Mortality was 17% in 117 hospitals with strict management protocols and was 27% in 512 hospitals without protocols. Other measures include goal-directed fluid therapy, general respiratory and circulatory support, intravenous broad-spectrum antibiotics, and insertion of a double-barreled NG tube, and a urinary catheter. An intravenous PPI is given routinely after surgery. Non-operative management of ulcer perforation should seldom be practiced. It involves NG suctioning, parenteral antibiotics, and 4 fluids. In a RCT, Crofts and Associates 138 assigned patients with the presumptive diagnosis of perforated peptic ulcers to either conservative treatment or prompt surgery. Overall morbidity and mortality rates, 5%, were low and similar in the medical and surgical groups. Of the 40 patients assigned to conservative treatment, 11 showed no improvement within 12 hours and underwent operation. 3 of these 11 patients were found to have perforated carcinomas, 2 gastric and 1 sigmoid colon. Findings of the study highlight common objections to the use of non-operative management, uncertainty of the site of perforation, the possibility of a perforated GI tumor, and atrophic momentum making spontaneous sealing unlikely. Older adults tolerate sepsis poorly. Any delay in definitive treatment leads to poor outcomes. Surgical therapy. Perforated gastroduodenal ulcer carries a high mortality rate. In a review of surgery for perforated ulcers between 2011 and 2013 in Denmark, the 90-day mortality was 25.5% among 726 patients. Reoperation was required in 124 patients, 17.1%, approximately one-third of them caused by persistent leaks. 139 Bowie and Associates 140 identified preoperative shock, major medical illnesses, and perforation longer than 12 hours as important adverse prognostic factors. The PULP score was recently developed from a cohort of 2,668 patients who received surgery in 11 hospitals across Denmark. Variables included were age greater than 65 years, active malignant disease or acquired immunodeficiency, cirrhosis, glucocorticoid use, perforation more than 24 hours, shock, raised serum creatinine level, and American Society of Anesthesiologists, ASA, score greater than 1. The PULP score was accurate in predicting mortality from ulcer perforation, a ROC of 0.83, 0.141. The score, however, has not been validated in centers outside Denmark. The controversies in the operative management of perforated peptic ulcers have revolved around the choice between laparoscopic and open repair and the need for a definitive ulcer operation after closure of the perforation, and which definitive operation to perform. Treatment also differs for duodenal and gastric perforations. Simple closure of a perforated duodenal or a juxtapyloric ulcer with the use of an omental patch is widely practiced. Meta-analyses of 3 RCTs, 2 from Hong Kong and the Dutch Lama study, that compared laparoscopic to open surgical treatment of perforated peptic ulcers tends to favor laparoscopic repair with respect to rates of abdominal septic complications, or 0.66, 95% CI, 0.3 to 1.47, and pulmonary complications, or 0.43, 95% CI, 0.17 to 1.12, 142, thus, laparoscopic repair should, at the least, be considered not inferior to open repair. There may, however, have been selection bias in these RCTs. Poor risk patients, those with delayed presentations, shock, and with significant comorbidities, may be better suited for a laparotomy. Large perforations, greater than 10 mm, suggest sizable ulcerations and should also be managed by laparotomy. Often, gastric resections are required in such patients. GU accounts for approximately 20% of perforated peptic ulcers. Epidemiologic data suggest a rising proportion of GUS among perforated ulcers, especially in older adult patients who use NSAIDs. Patients with perforated GUS are more likely to be older and to have significant comorbid illnesses, making their prognosis less favorable. As with perforated DUS, there has been a debate regarding the choice of surgery for perforated GUS. Simple closure should be offered to small perforations at the prepyloric area. The optimal treatment of an angular notch GU along the lesser curvature should entail an antrectomy and lesser curve ulcer excision, followed by either a Billroth type I or II reconstruction. The role of vagotomy is unclear. The advocates for primary resection in perforated GUS argue that mortality rates after gastrectomy are not increased and that the rate of postoperative ulcer-related complications is reduced. The arguments for primary resection also include the possibility that the ulcer is malignant. Malignancy is seen in approximately 6% of perforated GUS. 143 in a retrospective series comprising 287 perforated GUS, death occurred in 21.5% of patients who underwent patch closure alone and in 24.3% of those who underwent gastric resections. 144 in HP-associated ulcers, HP eradication reduces the relapse of ulceration after patch repair. In a RCT from Hong Kong, 99 patients after patch repairs for perforated ulcers were assigned to HP eradication or a course of PPI. At 1 year, there were fewer relapses in those given HP eradication, 4.8% versus 38.1%. 0.145. A meta-analysis of 5 RCTs that compared simple closure plus HP eradication to closure alone in patients with perforated DU showed that the pooled incidence of ulcer relapse in the year after HP eradication was 5.2% compared to 35.2% in those without eradication. These data support the use of simple closure in the majority of perforated DUS. 146. Obstruction. Gastric outlet obstruction is now an infrequent complication of PUD. Its clinical manifestations, nausea and postprandial vomiting, abdominal fullness, pain, and early satiety, are discussed in chapters 15 and 50, as is the diagnostic approach to patients presenting with possible gastric outlet obstruction. Gastric outlet obstruction should alert clinicians to possible malignancy, see chapter 54. Medical therapy. Patients with obstructing peptic ulcers are often volume depleted. The loss of fluid, hydrogen ions, and chloride ions in the vomitus leads to hypochloremic, hypokalemic metabolic alkalosis. The patient should be volume resuscitated with normal saline followed by potassium replacement once urine output is adequate. In severely malnourished patients, parenteral nutrition should be considered. Decompression of the stomach by a large bore NG tube relieves vomiting, helps to monitor fluid loss, and allows the stomach to regain its tone. A high-volume, non-bile stained aspirate can help distinguish gastric outlet obstruction from a high small bowel obstruction. Use of N4-PPI reduces gastric acid output, making fluid and electrolyte management easier. PPI therapy also initiates ulcer healing, ameliorates inflammatory edema, and assists in resolving obstruction. Approximately half of patients respond to this management. Improvement is especially noticeable in patients with active ulceration and edema. Surgery is, therefore, deferred until after an adequate trial of conservative management. Other factors that may influence the decision to proceed to surgery are chronicity, a history of previous ulcer complication, and the patient's age and general medical condition. Furthermore, many authorities argue for initial endoscopic dilation before surgery. Endoscopic therapy. Fig. 53.6. A through-the-scope dilation of an obstructed pylorus caused by an ulcer. The procedure was performed under fluoroscopic guidance. A dual-channel endoscope with a 3.7 mm therapeutic channel was used. A. The stricture was first traversed with a biliary-type guide wire, arrowhead. A through-the-scope balloon was passed over the guide wire across the stricture. B. A waist, representing the stricture, arrow, was observed and was nearly abolished on balloon inflation. C. Endoscopic balloon dilation has been used successfully in patients with gastric outlet obstruction from PUD, Fig. 53.6, .147-149. During endoscopic examination, the stenosis is traversed by means of a biliary-type guide wire with a flexible tip. A low-compliance through-the-scope balloon is then passed over the guide wire, and dilation can be seen through the endoscope. The use of a balloon is preferred because its inflation produces a uniform radial force, which has a theoretical advantage over the longitudinal shearing force associated with the use of conventional dilators. The procedure is typically performed with fluoroscopic guidance. A regimen of gradual dilation over 2 or 3 sessions seems sensible. The targeted diameter is unclear. Many authorities recommend dilation to 15 mm, which is often associated with relief of symptoms. The presence of gastric atony also contributes to symptoms. The risk of perforation increases with the size of balloon. Endoscopic series reported immediate relief of obstruction in 78% to 100% of cases. In a small series of HP-infected patients, balloon dilation followed by HP eradication led to sustained symptom relief. 150 Surgical therapy. A variety of operations have been described for obstructing DUS, pyloric channel ulcers, and prepyloric ulcers. They include vagotomy with either a drainage procedure, gastrojejunectomy or pyloroplasty, or an antrectomy. In the unusual event of an obstructing prepyloric GU, an antrectomy followed by a Billroad type I gastroduodenostomy is the procedure of choice. Stress ulcers. Stress-related gastric and duodenal mucosal injury, stress ulcers, is an illness of the critically ill who are typically cared for in an ICU. The etiology of stress ulceration is probably related to mucosal ischemia and splanchnic hypoperfusion from shock or low cardiac output. Fortunately, only a small proportion of patients with stress-related mucosal lesions have clinically overt GI bleeding. In a cohort STUDY151 of 2,252 ICU patients, only 1.5% developed clinically important bleeding. Respiratory failure, or 15.6, and coagulopathy, or 4.3, were independent predictive factors for bleeding stress ulcers. In 2015, a prospective STUDY152 of 1,034 patients admitted to ICUs was published. Clinically important GI bleeding occurred in 2.6% of patients. Those with 3 or more comorbid illnesses, liver disease, receiving renal replacement therapy, and with a high organ failure score were at risk. Patients in the ICU with traumatic brain injuries and burns also belong to a high-risk group of developing GI bleeding. Across different studies, there appears to be different candidate predictors for bleeding. The use of enteral nutrients buffers acid and protects against bleeding. PPI, H2RA and sucralfate are drugs used for stress ulcer prophylaxis. In a network meta-analysis of 57 RCTs, N equals 7,293, Al-Hazani and Associates 153 showed that PPIs were more effective for preventing clinically important bleeding than H2RA, or 0.38, sucralfate, or 0.30, or placebo, or 0.24. PPIs, however, increased the risk of nosocomial pneumonia compared with H2RA, or 1.27, sucralfate, or 1.65, and placebo, or 1.52. There is concern that acid suppression predisposes patients to nosocomial infection, probably linked to gut dysbiosis. 154 A European multi-center study randomized 3,298 ICU patients to receive 40 mg of intravenous PPI or placebo and found that deaths by 90 days were similar between groups, 31.1% versus 30.4%. The rate of composite adverse events, gastrointestinal bleeding, Clostridium difficile infection, pneumonia, or myocardial ischemia, were comparable, 21.9 versus 22.6%. There were fewer clinically important bleeding events in the PPI group, 2.5 versus 4.2%. 155 Full references for this chapter can be found on www.expertconsult.com. References: Black J., Duncan W., Durant D. Definition and antagonism of histamine H2 receptors. Nature 1972, 236:365-90. Marshall B., Warren J. Unidentified curved bacilli in the stomachs of patients with gastritis and peptic ulcer. Lancet 1984, 1:1311-5. Sonnenberg A. Causes underlying the birth cohort phenomenon of peptic ulcer, Analysis of mortality data 1911-2000, England and Wales. Int J. Epidemial 2006, 35:1097. Sung J. J., Kuipers E. J., Elsirag H. B. Systematic Review, The Global Incidence and Prevalence of Peptic Ulcer Disease. Aliment Pharmacolder 2009, 29:938-46. Lee Z., Zo D., Ma X., ETAL Epidemiology of Peptic Ulcer Disease, Endoscopic Results of the Systematic Investigation of Gastrointestinal Disease in China. AMJ Gastroenterol 2010, 105:2577. Lao Jai, Sung J., Hill C., ETAL Systematic Review of the Epidemiology of Complicated Peptic Ulcer Disease, Incidence, Recurrence, Risk Factors, and Mortality. Digestion 2011, 84:10213. Lane L., Yang H., Chong S.C., ETAL Trends for Incidence of Hospitalization and Death Due to GI Complications in the United States from 2001 to 2009. AMJ Gastroenterol 2012, 107:1195. Wu Psi, Wu Ch, Wu Ms, et.al. A nationwide population-based cohort study shows reduced hospitalization for peptic ulcer disease associated with H. pylori eradication and proton pump inhibitor use. Clin Gastroenterol Hepital 2009, 7:42731. Wang I, Purity. The prevalence and incidence of Helicobacter pylori-associated peptic ulcer disease and upper gastrointestinal bleeding throughout the world. Gastrointestinal Clin NM 2011, 21:61335. Feinstein LB, Holman RC, Yorita Christensen KL, ETAL Trends in Hospitalizations for Peptic Ulcer Disease, United States, 1998 to 2005. Emergency Infect Dis 2010, 16:1410-8. Sanchez Delgado J., Jeannie, Suarez D., ETAL. Has H. pylori prevalence in bleeding peptic ulcer been underestimated? A metaregression. AMJ Gastroenterol 2011, 106:398-405. All BL, Hamlet A., Dallenbach J., et.al. A mechanism by which Helicobacter pylori infection of the antrum contributes to the development of duodenal ulcer. Gastroenterology 1996, 110:1386-94. L. Omar M. Mechanisms of increased acid secretion after eradication of Helicobacter pylori infection. Gut 2006, 55:144-6. Garcia Rodriguez L.A., Hernandez Diaz S. Relative risk of upper gastrointestinal complications among users of acetaminophen and nonsteroidal anti-inflammatory drugs. Epidemiology 2001, 12:576. Wilcox C., Allison J., Benzoli K., ETAL Consensus Development Conference on the Use of Nonsteroidal Anti-Inflammatory Agents, including cyclooxygenase 2 enzyme inhibitors and aspirin. Clin Gastroenterol Hepital 2006, 4:1082-9. Svensson H.T., Mellemkjær L., Blot W.J., ETAL Risk of upper gastrointestinal bleeding associated with use of low-dose aspirin. AMJ Gastroenterol 2000, 95:2218-24. Lanis A., Perez Isama, Pho F., et.al. A nationwide study of mortality associated with hospital admission due to severe gastrointestinal events and those associated with nonsteroidal anti-inflammatory drug use. AMJ Gastroenterol 2005, 100:1685-93. Jarnazan I., Scarpignato C., Holmgren E., ETAL Mechanisms of damage to the gastrointestinal tract from nonsteroidal anti-inflammatory drugs. Gastroenterology 2018, 154:514. Fiorucci S., Distrutti E., Santucci L. NSAIDS, Coxon Psinid and H2S releasing NSAIDS, What Lies Beyond the Horizon. Dig Liver Dis 2007, 39:1043-51. Green JRFW, Kaplan MM, Curtis LE, ETAL Effect of acid and pepsin on blood coagulation and platelet aggregation. A possible contributor: prolonged gastroduodenal mucosal hemorrhage. Gastroenterology 1978, 74:38-43. Huang J.Q., Shrither S., Hunt R.H. Role of Helicobacter pylori infection and nonsteroidal anti-inflammatory drugs in peptic ulcer disease, a meta-analysis. Lancet 2002, 359:1422. Vergara M., Catalan M., Gisbert J.P., Calvet X. Meta-analysis, Role of Helicobacter pylori eradication in the prevention of peptic ulcer in NSAID users. Aliment Pharmacolder 2005, 21:1411-8. Chan F.K., Sung Jai, Chung S.C., ETAL randomized trial of eradication of Helicobacter pylori before starting nonsteroidal anti-inflammatory drug therapy to prevent peptic ulcers. Lancet 1997, 350:975-9. Chan F.K., to K.F., Wu J.C., ETAL eradication of Helicobacter pylori and risk of peptic ulcers in patients starting long-term treatment with nonsteroidal anti-inflammatory drugs, a randomized trial. Lancet 2002, 359:913. Leontiadis GI, Sredharan A, Dorward S, ETAL systematic reviews of the clinical effectiveness and cost-effectiveness of proton pump inhibitors in acute upper gastrointestinal bleeding. Health Technol Assess 2007, 11:1164. Chan FK, Chung SC, Soon by, ETAL preventing recurrent upper gastrointestinal bleeding in patients with Helicobacter pylori infection who are taking low-dose aspirin or naproxen. N. English JMed 2001, 344:96773. Hockey CJ, Tulase Z, Chepansky L. ETAL randomized controlled trial of Helicobacter pylori eradication in patients on nonsteroidal anti-inflammatory drugs. Help NSAIDS study. Lancet 1998, 352:101621. Chan FK, Ching Jai, Soon by, ETAL effects of Helicobacter pylori infection on long-term risk of peptic ulcer bleeding in low-dose aspirin users. Gastroenterology 2013, 144:52835. Pechari, Prindeval T, Pecha BS, ETAL association of cocaine and methamphetamine use with giant gastroduodenal ulcers. AMJ Gastroenterol 1996, 91:25237. Lanza FL, Hunt RH, Thompson IB. ETAL endoscopic comparison of esophageal and gastroduodenal effects of risdronate and alendronate in postmenopausal women. Gastroenterology 2000, 119:6318. Con H, Blitzer B. Non-association of adrenocorticosteroid therapy and peptic ulcer. N. English JMed 1976, 294:4739. Piper J., Ray W., Doherty J., Griffin M. Corticosteroid use and peptic ulcer disease, role of nonsteroidal anti-inflammatory drugs. An Intern Med 1991, 114:73540. Gibril F., Schumann M., Pace A., Jensen RT. Multiple endocrine neoplasia type I and Zollinger-Ellison syndrome, a prospective study of 107 cases in comparison with 1,009 cases from the literature. Medicine, Baltimore, 2004, 83:4383. Jensen RT. Gastrointestinal abnormalities and involvement in systemic mastocytosis. Hematol Onkel Clin North M 2000, 14, 579-623. Wang GL, Wang VW, Chan Y, ETAL high incidence of mortality and recurrent bleeding in patients with Helicobacter pylori negative idiopathic bleeding ulcers. Gastroenterology 2009, 137:52531. Lee XQ, Anderson TB, Ahlstrom M., Wadolf L. Comparison of inhibitory effects of the proton pump inhibiting drugs omeprazole, esomeprazole, lansoprazole, pantoprazole, and rabeprazole on human cytochrome P450 activities. Drug Metabdispose 2004, 32:8217. Klotz U, Schwab M., Triber GCYP2C19 polymorphism and proton pump inhibitors. Basic Clin Pharmacol Toxicol 2004, 95:28. Majumdar SR, Sumare SB, Faray Fa, ETAL chronic acid-related disorders are common and under-investigated. AMJ Gastroenterol 2003, 98:240914. Gisbert J.P., Calvet X Helicobacter pylori test and treat strategy for management of dyspepsia, a comprehensive review. Clintran Slow Gastroenterol 2013, 4E32. Ford AC, Cum M, Moe Yeti P, ETAL Helicobacter pylori test and treat or endoscopy for managing dyspepsia, an individual patient data meta-analysis. Gastroenterology 2005, 128:183844. Moe Yeti PM, Lacey B., Andrew CN. ETAL AC and CAG Clinical Guideline, Management of Dyspepsia. AMJ Gastroenterol 2017, 112:988-1013. Malfurthiner P., Migrod F., Omarane CA, ETAL Management of Helicobacter pylori Infection. The Maastricht v/Florence Consensus Report. European Helicobacter and Microbiota Study Group and Consensus Panel. Gut 2017, 66:630. Kanga 3rd C. Vacuole and upper GI malignancy, uncomplicated dyspepsia, and the age threshold for early endoscopy. AMJ Gastroenterol 2002, 97:603. Feldman M., Burton Me. Histamine 2 receptor antagonists, standard therapy for acid peptic diseases. N. English J. Med 1990, 323:1672-80. Patel N., Ward U., Rogers M.J., Primrose J.N. Nighttime or morning dosing with H2 receptor antagonists, studies on acid inhibition in normal subjects. Aliment Pharmacolder 1992, 6:381-7. Michelet Sonity Pa Peptic ulcer disease in pregnancy. Gastroenterol Clin North M 1992, 21:817-26. Cantu T.G., Correct J.S. Central nervous system reactions to histamine 2 receptor blockers. An Intern Med 1991, 114:1027-34. Wilder Smith C.H., Ernst T., Genon I.M., ETAL tolerance to oral H2 receptor antagonists. Dig Dis Sci 1990, 8:976-83. 819.E1 References are Richter J.M., Kolditz G.A., Hughes D.M., ETAL cimetidine and adverse reactions, a meta-analysis of randomized clinical trials of short-term therapy. AMJ Med 1989, 87:278-84. Garcia Rodriguez L.A., Jic H. Risk of gynecomastia associated with cimetidine, omeprazole, and other anti-ulcer drugs. BMJ 1994, 308:5036. H. Enston PD drug interactions with anti-secretory agents. Aliment Pharmacolder 1991, 5:121-8. R. Abinson M., Horn J. Clinical Pharmacology of Proton Pump Inhibitors, What the Practicing Physician Needs to Know. Drugs 2003, 63:2739-54. Zhang L., Mei Q., Li Q.S., et.al. The effect of cytochrome P2C19 and interleukin-1 polymorphisms on H. pylori eradication rate of 1-week triple therapy with omeprazole or rabeprazole, amoxicillin, and clarithromycin in Chinese people. J. Clin Pharm There 2010, 35, 713-22. W. Alf MM, Sachs G. Acid suppression, optimizing therapy for gastroduodenal ulcer healing, gastroesophageal reflux disease, and stress-related erosive syndrome. Gastroenterology 2000, 118s 931. Via Kill and prescribing proton pump inhibitors, is it time to pause and rethink? Drugs 2012, 72:437-45. LUEA pharmacokinetic concerns in the selection of anti-ulcer therapy. Aliment Pharmacolder 1999, 13:11-6. K. Walk CS, Loc YK. Meta-analysis, the effects of proton pump inhibitors on cardiovascular events and mortality in patients receiving clopidogrel. Aliment Pharmacolder 2010, 31:810-23. F. Ox J.J., Brouwer Ma, Van Oygen M.G., ETAL concomitant use of clopidogrel and proton pump inhibitors, impact on platelet function and clinical outcome. A systematic review. Hart 2013, 99:527. Behat DL, Cryer BL, Contant CF, ETAL clopidogrel with or without omeprazole in coronary artery disease. N. English J. Med 2010, 363:1909-17. O'Donoghue ML, Braunwald E., Antman M., ETAL pharmacodynamic effect and clinical efficacy of clopidogrel and prasugrel with or without a proton pump inhibitor, an analysis of 2 randomized trials. Lancet 2009, 374:989-97. T. Argonic L. Discontinuing long-term PPI therapy, why, with whom, and how. AMJ Gastrointestinal 2018, 113:519-28. H. Ori Y, Iman Ishii A, Matsukawa J, ETAL 15, 2-fluorophenyl, 1, pyridine 3-eel sulfonyl, 1H pyrrol 3YL and methylmethanamine monofumarate, TAC 438, a novel and potent potassium competitive acid blocker for the treatment of acid-related diseases. J. Pharmacol EXP There 2010, 335:2318. S. Akari Y, Mori Y, Okamoto H, ETAL acid inhibitory effects of vonoprazan 20 mg compared with esomeprazole 20 mg or rabeprazole 10 mg in healthy adult male subjects, a randomized open-label crossover study. Aliment Pharmacol There 2015, 42:719-30. MIWAH, Udo N, Wattery J, ETAL randomized clinical trial, efficacy and safety of vonoprazan versus lansoprazole in patients with gastric or duodenal ulcers. Results from 2 phase 3, non-inferiority randomized controlled trials. Aliment Pharmacol There 2017, 45:240-52. KOYT, Oda K, Funeo N, ETAL vonoprazan prevents low-dose aspirin-associated ulcer recurrence, randomized phase 3 study. Gut 2018, 67:1033-41. M. Izokamai Y, Oda K, Funeo N, ETAL vonoprazan prevents ulcer recurrence during long-term NSAID therapy, randomized, lansoprazole-controlled non-inferiority and single-blind extension study. Gut 2018, 67:1042-51. M. C. Karthi DM Sucralfate. N. English J. Med 1991, 325:1017-25. W. Agstaff A. J., Benfield P., Monk J. P. Colloidal bismuth subcitrate. A review of its pharmacodynamic and pharmacokinetic properties, and its therapeutic use in peptic ulcer disease. Drugs 1988, 36:132-57. W. Alt RP. Misoprostol for the treatment of peptic ulcer and anti-inflammatory drug-induced gastroduodenal ulceration. N. English J. Med 1992, 327:1575-80. C. Hen M. C., Amirian Day, Toomey M., ETAL prostanoid inhibition of canine parietal cells, mediation by the inhibitory guanosine triphosphate binding protein of adenylate cyclase. Gastroenterology 1988, 94:1121-9. S. Ong J. J., Chung S. C., Ling T. K., ETAL antibacterial treatment of gastric ulcers associated with Helicobacter pylori. N. English J. Med 1995, 332:139-42. F. Ford A. C., Delaney B. C., Foreman D., ETAL eradication therapy in Helicobacter pylori positive peptic ulcer disease, systematic review and economic analysis. AMJ Gastroenterol 2004, 99:1833-55. Malfurthiner P., Kirchner T., Kist M., ETAL Helicobacter pylori eradication and gastric ulcer healing comparison of 3 pantoprazole-based triple therapies. BYK Advanced Gastric Ulcer Study Group. Aliment Pharmacol There 2003, 17:1125-35. Higuchi K., Fujiwara Y., Tominaga K., ETAL. Is eradication sufficient to heal gastric ulcers in patients infected with Helicobacter pylori? A randomized, controlled, prospective study. Aliment Pharmacol There 2003, 17:1117. Yeomans N.D., Tulase Z., Juhez L., ETAL. A comparison of omeprazole with ranitidine for ulcers associated with nonsteroidal anti-inflammatory drugs. Acid suppression trial, ranitidine versus omeprazole for NSAID-associated ulcer treatment, Astronaut, Study Group. N. English J. Med 1998, 338:7 1926. Agrawal N.M., Campbell D.R., Safti Ma, ETAL Superiority of lansoprazole versus ranitidine in healing nonsteroidal anti-inflammatory drug-associated gastric ulcers, results of a double-blind, randomized, multi-center study. NSAID-associated gastric ulcer study group. Arch Intern Med 2000, 160:1455-61. Goldstein J.L., Johansson J.F., Hawkey C.J., ETAL Clinical Trial, Healing of NSAID-associated gastric ulcers in patients continuing NSAID therapy. A randomized study comparing ranitidine with esomeprazole. Aliment Pharmacolor 2007, 26:110111. Roth S., Agrawal N., Mahold M., ETAL Misoprostol heals gastroduodenal injury in patients with rheumatoid arthritis receiving aspirin. Arch Intern Med 1989, 149:775-9. Hawkey C.J., Karash J.A., Zazapansky L., ETAL omeprazole compared with misoprostol for ulcers associated with nonsteroidal anti-inflammatory drugs, omeprazole versus misoprostol for NSAID-induced ulcer management, Omnium, Study Group. N. English J. Med 1998, 338:727-34. Kaya M.H., Otani K., Ching J.Y.L., ETAL misoprostol heals small bowel ulcers in aspirin users with small bowel bleeding. Gastroenterology 2018, S00165085, 18, 346985. Taha Az, McCloskey C., McScheming P., McConaughey A. Misoprostol for small bowel ulcers in patients with obscure bleeding taking aspirin and nonsteroidal anti-inflammatory drugs, Masters a randomized, double-blind, placebo-controlled, Phase 3 trial. Lancet Gastroenterol Hepatal 2018, 3:469-76. Lancaster Smith M.J., Jaderberg Me, Jackson Ranitidine in the treatment of nonsteroidal anti-inflammatory drug-associated gastric and duodenal ulcers. Gut 1991, 32:252-5. Singh G., Triadaphilopoulos G. Epidemiology of NSAID-induced GI complications. J. Room et al. 1999, 26:1824. Rostam A., Wells G., Tugwell P., ETAL Prevention of NSAID-induced gastroduodenal ulcers, Cochrane Review. Cochrane Database SYST Rev 2000, 4CD002296. Chan F.K., Kaya M., Tanagawa T., ETAL Similar efficacy of proton pump inhibitors vs H2 receptor antagonists in reducing risk of upper gastrointestinal bleeding or ulcers in high-risk users of low-dose aspirin. Gastroenterology 2017, 152:10510. Chan F.K., Sung J.J., Ching Jai, ETAL randomized trial of low-dose misoprostol and naproxen versus nabumetone to prevent recurrent upper gastrointestinal hemorrhage in users of nonsteroidal anti-inflammatory drugs. Aliment Pharmacolor 2001, 15:1924. Graham D.Y., Agrawal N.M., Campbell D.R., ETAL ulcer prevention in long-term users of nonsteroidal anti-inflammatory drugs, results of a double-blind, randomized, multi-center, active and placebo-controlled study of misoprostol vs lansoprazole. Arch Intern Med 2002, 62:169-75. Regula J., Butruck E., Deckers C.P., ETAL Prevention of NSAID-associated gastrointestinal lesions, a comparison study pantoprazole versus omeprazole. AMJ Gastroenterol 2006, 101:1747-55. Lanas A., Garcia Rodriguez L.A., Arroyo M.T., ETAL effect of anti-secretory drugs and nitrates on the risk of ulcer bleeding associated with nonsteroidal anti-inflammatory drugs, antiplatelet agents, and anticoagulants. AMJ Gastroenterol 2007, 102:507-15. Chan F.K., to KF, Wu JC, ETAL eradication of Helicobacter pylori and risk of peptic ulcers in patients starting long-term treatment with nonsteroidal anti-inflammatory drugs, a randomized trial. Lancet 2002, 359:913. Chan FK, Hung LC, Soon by, ETAL Selexib versus diclofenac and omeprazole in reducing the risk of recurrent ulcer bleeding in patients with arthritis. N. English JMed 2002, 347:210410. Rostam A., Muir K., Dube C., ETAL Gastrointestinal Safety of Cyclooxygenase 2 Inhibitors, a Cochrane Collaboration Systematic Review. Clin Gastroenterol Hepatil 2007, 5:8-1828. Chan FK, Hung LC, Soon by, ETAL Selexib versus diclofenac plus omeprazole in high-risk arthritis patients, results of a randomized double-blind trial. Gastroenterology 2004, 127:1038-43. Chan FK, Wang VW, Soon by, ETAL combination of a cyclooxygenase 2 inhibitor and a proton pump inhibitor for prevention of recurrent ulcer bleeding in patients at very high risk, a double-blind randomized trial. Lancet 2007, 369:1621-6. Bombardier C., Lane L., Ryson A., ETAL comparison of upper gastrointestinal toxicity of rofecoxib and naproxen in patients with rheumatoid arthritis. Vigor Study Group. N. English JMed 2000, 343:1528. Bress Allier Rs., Sandler Rs., Chuan H., ETAL cardiovascular events associated with rofecoxib in a colorectal adenoma chemoprevention trial. N. English JMed 2005, 352:1092-102. 1 SD, McMurray JJV, Pfeffer Ma, ETL. For the adenoma prevention with Selexib, APC, study investigators. Cardiovascular risk associated with Selexib in a clinical trial for colorectal adenoma prevention. N. English JMed 2005, 352:1071-80. Cannon CP, Curtis SP, Fitzgerald GA, ETAL cardiovascular outcomes with etorixib and diclofenac in patients with osteoarthritis and rheumatoid arthritis in the multinational etorixib and diclofenac arthritis long-term, MEDAL, program, a randomized comparison. Lancet 2006, 368:1771-81. McGettigan P., Henry D. Cardiovascular Risk and Inhibition of Cyclooxygenase, a systematic review of the observational studies of selective and non-selective inhibitors of cyclooxygenase 2. JAM Med Association 2006, 296:1633-44. N. Eason SE, Yeomans ND, Solomon DH, ETAL cardiovascular safety of Selexib, naproxen, or ibuprofen for arthritis. N. English JMed 2016, 375, 2625-1929. Sihan FKL, Ching JYL, PSYK, ETAL gastrointestinal safety of Selexib versus naproxen in patients with cardiothrombotic diseases and arthritis after upper gastrointestinal bleeding, concern an industry-independent, double-blind, double-dummy, randomized trial. Lancet 2017, 389:2375-82. P. Earson Ta, Blair SN, Daniels SR, ETAL AHA Scientific Statement, AHA Guidelines for Primary Prevention of Cardiovascular Disease and Stroke, 2002 Update, 71-0226. Circulation 2002, 106:388-91. Hearn-Shaw SA, Logan RF, Low D, ETAL Acute Upper Gastrointestinal Bleeding in the UK, Patient Characteristics, Diagnoses and Outcomes in the 2007 UK Audit. Gut 2011, 60:1327-35. Barkin A., Bardu M., Kuipers EJ, ETAL International Consensus Recommendations on the Management of Patients with Non-Varicose Upper Gastrointestinal Bleeding. An Intern Med 2010, 152:10113. Lin H.J., Wang K., Peng C.L., et.al. Early or delayed endoscopy for patients with peptic ulcer bleeding, a prospective randomized controlled trial. J. Clin Gastroenterol 1996, 22:26771. Lee J.G., Turnipseed S., Romano P.S., ETAL endoscopy-based triage significantly reduces hospitalization rates and costs of treating upper GI bleeding, a randomized controlled trial. Gastrointestinal 1999, 50:75561. Cipoletta L., Bianco Ma, Rotondano G., ETAL outpatient management for low-risk non-varicose upper GI bleeding, a randomized controlled trial. Gastrointestinal 2002, 55:15. B. Arkin A., Martel M., Tubudi Y., Rami, Bardu M. Endoscopic hemostasis in peptic ulcer bleeding for patients with high-risk lesions, a series of meta-analyses. Gastrointestinal 2009, 69:78699. Rockall Ta, Logan R.F., Devlin H.B., Northfield T.C. Risk assessment after acute upper gastrointestinal hemorrhage. Gut 1996, 38:31621. Blatchford O., Murray W.R., Blatchford M. A risk score to predict need for treatment for upper gastrointestinal hemorrhage. Lancet 2000, 356:131821. Stanley A. J., Lane L., Dalton H. R., Engu J. H., Schultz M., Abazi R., ETAL comparison of risk scoring systems for patients presenting with upper gastrointestinal bleeding, International Multi-Center Prospective Study. BMJ 2017, 356:6432. Forrest J. A., Finlayson N. D., Shearman D. J. Endoscopy in gastrointestinal bleeding. Lancet 1974, 2:39447. Lane L., Jensen D. M. Management of Patients with Ulcer Bleeding. AMJ Gastroenterol 2012, 107:34560. 53 references 819.E3 Jensen DM, COVAX 2, Jutabha R., ETAL randomized trial of medical or endoscopic therapy to prevent recurrent ulcer hemorrhage in patients with adherent clots. Gastroenterology 2002, 123:40713. 115 Blow BL, Gostout CJ, Shearman K., ETAL recurrent bleeding from peptic ulcer associated with adherent clot, a randomized study comparing endoscopic treatment with medical therapy. Gastrointestinal 2002, 56:16. Kahi CJ, Jensen DM, Sung JJ, ETAL endoscopic therapy versus medical therapy for bleeding peptic ulcer with adherent clot, a meta-analysis. Gastroenterology 2005, 129:85562. Johnston J.H. The sentinel clot and invisible vessel, pathologic anatomy of bleeding peptic ulcer. Gastrointestinal 1984, 30:3135. Jensen DM, Owning GV, COVAX TOG, ETAL Doppler endoscopic probe as a guide to risk stratification and definitive hemostasis of peptic ulcer bleeding. Gastrointestinal 2016, 83:12936. Jensen DM, COVAX TOG, Owning GV, ETAL Doppler endoscopic probe monitoring of blood flow improves risk stratification and outcomes of patients with severe non-varicose upper gastrointestinal hemorrhage. Gastroenterology 2017, 152:1310-8. Vergara M., Bennett C., Calvet X., Gisbert J. P. Epinephrine injection versus epinephrine injection and a second endoscopic method in high-risk bleeding ulcers. Cochrane Database SYST Rev 2014-10 CD 005584. Sung J. J., Tswa K. K., Lai L. H., ETAL endoscopic clipping versus injection and thermocoagulation in the treatment of non-varicose upper gastrointestinal bleeding, a meta-analysis. Gut 2007, 56:136473. 122. Schmidt A., Golder S., Goetz M., et al. Over-the-scope clips are more effective than standard endoscopic therapy for patients with recurrent bleeding of peptic ulcers. Gastroenterology 2018, 05:037. EPUB ahead of print. Lebens J., Pates U., Leusing C., ETAL efficacy of primed infusions with high-dose ranitidine and omeprazole to maintain high intragastric pH in patients with peptic ulcer bleeding, a prospective randomized controlled study. Gut 1997, 403641. Sung JJY, Barkham A., Kuipers EJ, ETAL intravenous esomeprazole for prevention of recurrent peptic ulcer bleeding. Anint Med 2009, 150:45564. Leontiadis GI, Sharma VK, Houghton CW proton pump inhibitor treatment for acute peptic ulcer bleeding. Cochrane Database SYST Rev 2006, 25 CD 902094. Newman I., Leitlier LM, Radaji, ETAL comparison of different regimens of proton pump inhibitors for acute peptic ulcer bleeding. Cochrane Database SYST Rev 2013, 60 CD 007999. Lao Jai, Long WK, Wu JC, ETAL omeprazole before endoscopy in patients with gastrointestinal bleeding. N. English J. Med 2007, 356:163140. Wang Year, Richter J.E., Dempsey DT Trends and Outcomes of Hospitalizations for Peptic Ulcer Disease in the United States, 1993 to 2006. Ann SURG 2010, 251:518. Jarath V., Kahan BC, Logan RF, ETAL National Audit of the Use of Surgery and Radiological Embolization after Failed Endoscopic Hemostasis for Non-Varicose Upper Gastrointestinal Bleeding. BRJ SURG 2012, 99:167280. L. Munzer BJ, Young SD, Anatomy JM, ETAL Systematic Review of the Predictors of Recurrent Hemorrhage after Endoscopic Hemostatic Therapy for Bleeding Peptic Ulcer. AMJ Gastroenterol 2008, 103:262532. Lao Jai, Sung JJY, Lam Yat, ETAL Endoscopic Retreatment compared with surgery in patients with recurrent bleeding after initial endoscopic control of bleeding ulcers. N. English J. Med 1999, 340:7516. Poxon VA, Keithley MRB, Dykes PW, ETAL Comparison of Minimal and Conventional Surgery in Patients with Bleeding Ulcer, a Multi-Center Trial. BRJ SURG 1991, 78:13445. Millet B., Hay JM, Valor P., ETAL Emergency Surgical Treatment for Bleeding Duodenal Ulcer, Oversewing plus Vagotomy versus Gastric Resection, a Controlled Randomized Trial French Associations for Surgical Research. World JSURG 1993, 17:56874. Schroeder VT, Pappas T., Vaslev S., ETAL vagotomy/drainage is superior to local oversew in patients who require emergency surgery for bleeding peptic ulcers. An SURG 2014, 259:111118. 819.E4 references K. Ya M., Tse Y, Ang D., ETAL embolization versus surgery for peptic ulcer bleeding after failed endoscopic hemostasis, a meta-analysis. Endoskint Open 2014, 02:614. L. Ojai, Pitta Ianon R., Wang KT, Pinheiro NN, Chu PWY, Rernimitor R., ETAL prophylactic angiographic embolization after endoscopic control of bleeding to high-risk peptic ulcers, a randomized controlled trial. Gut 2018, 0:18. M. Mahler MH, Adamson S., Thompson RW, Mahler AM. Peptic ulcer perforation, PULP, Trial Group Multi-Center Trial of a Perioperative Protocol to Reduce Mortality in Patients with Peptic Ulcer Perforations. BRJSURG 2011, 98:80210. C. Rofts TJ, Park KGM, Steel RJC, ETL. A randomized trial of non-operative treatment for perforated peptic ulcer. N. English JMed 1989, 320:973. W. Ilhelmsen M., Mahler MH, Rosenstock S. Surgical complications after open and laparoscopic surgery for perforated peptic ulcer in a nationwide cohort. BRJSURG 2015, 102:3827. BOEJ, Choi Sky, Alagarat Nam TT, Pune Risk Stratification in Perforated Duodenal Ulcers, a prospective validation of predictive factors. NSURG 1987, 205:22. M. Mahler MH, Injabjerg MC, Adamson S., ETL. The peptic ulcer perforation, PULP, score, a predictor of mortality following peptic ulcer perforation, a cohort study. Acta Anesthesial Scan 2012, 56:65562. S. Anabria A., Villegas MI, Morales Urabi CH laparoscopic repair for perforated peptic ulcer disease. Cochrane Database SYST Rev 2013, 28 CD 004778. MCGGS, Sawyers JL Perforated gastric ulcers, a plea for management by primary gastric resection. Arch SURG 1987, 122:55561. Lang C., Hansen CP, Christensen A., ETAL Perforated gastric ulcer. BRJSURG 1988, 75:7589. NGEK, Lam Yat, Sung JJ, Young Mai, ETAL Eradication of Helicobacter pylori prevents recurrence of ulcer after simple closure of duodenal ulcer perforation randomized controlled trial. NSURG 2000, 231:1538. Tom Tit Chong P., Sirabumran Guang B., Vilaichon RK, ETAL Systemic Review and Meta-Analysis, Helicobacter pylori eradication therapy after simple closure of perforated duodenal ulcer. Helicobacter 2012, 17:14852. Lao Jai, Chung SC, Sung Jai, ETL. Through the scope balloon dilation for pyloric stenosis, long-term results. Gastrointestinal 1996, 43:98101. 148. Griffin SM, Chung SC, Long JW, Lee AK. Peptic pyloric stenosis treated by endoscopic balloon dilatation. BRJSURG 1989, 76:11478. 149 Craig Pye, Gillespie P.E. Through the endoscope balloon dilatation of benign gastric outlet obstruction. BMJ 1988, 297:396. 150. Lam Ya, Lao Jai, Feng trademark, ETAL endoscopic balloon dilation for benign gastric outlet obstruction with or without Helicobacter pylori infection. Gastrointestinal 2004, 60:22933. Cook DJ, Fuller HD, Guyot GH, ETAL risk factors for gastrointestinal bleeding in critically ill patients. Canadian Critical Care Trials Group. N. English JMed 1994, 333-7781. Cragg M., Perner A., Wettersluff J., ETAL prevalence and outcome of gastrointestinal bleeding and use of acid suppressants in acutely ill adult intensive care patients. Intensive Care Med 2015, 41:83345. Al-Hazan E.W., Al-Shamsi F., Belly Code E., ETAL efficacy and safety of stress ulcer prophylaxis in critically ill patients, a network meta-analysis of randomized trials. Intensive Care Med 2018, 44:111. Cook D., Guyot G. prophylaxis against upper gastrointestinal bleeding in hospitalized patients. N. English JMed 2018, 378:250616. Cragg M., Marker S., Perner A., Wettersluff J., Wise MP scaffold JCETAL pantoprazole in patients at risk for gastrointestinal bleeding in the ICU. N. English JMed 2018, 379:2199-208.